Very warm welcome to Ms. Punya Salila Srivastava, Secretary, Ministry of Health and Family Welfare, Government of India. Ma'am, we are honored to have you here with us. And I would also like to take this time to invite our honorable dignitaries to join us here. Welcome to all of you. Good morning, distinguished guests, industry members, ladies and gentlemen. It is our absolute honor to welcome you all to the National Stroke Summit 2025, organized by FICCI. Dear President,
chronic businesses suggest driven by a strong emphasis on digital integration and breakthrough innovations. This evolution Strengthen public-private partnerships, and advocate for proactive government initiatives. And in this, technology would continue to play a pivotal role. By leveraging advanced diagnostic tools, AI-driven decision-making systems, and cutting-edge treatment options, we can ensure timely and effective interventions. As we were coming up the lift, Madam Secretary made a mention that she got reminded. We were thanking her for the time that she's spending with us today. She said she got reminded of how friends and family in her lifespan have been impacted by stroke. And most of us have had that experience, unfortunately. So today it is great to see all of us standing here committed to address this major challenge. By focusing on education, awareness, and timely interventions, we can empower our communities and healthcare providers alike. Together, we can work towards a future where fewer lives are disrupted by stroke, ultimately paving the way for a healthier and a more resilient nation. Thank you so much, and I wish you all a very successful summit. Thank you.
Thank you, sir, for sharing the industry's perspective. And now I would like to request Dr. Anil Bonde, Honorable Member of Parliament, Chairperson, Indian Medical Parliaments Forum, to present the special address. Dr. Bonde is a distinguished Indian politician and a member of the Bharatiya Janata Party. He has held significant positions, including Minister of Agriculture in the Maharashtra government, and is currently serving as Member of Parliament in the Rajya Sabha. Dr. Bonde's background is in medicine with an MBBS and MD from Nagpur University. Sir, we look forward to hearing from you.
Bharat Mata Ki. Today, Dynamic Secretary of Ministry of Health and Family Welfare, Government of India, Ms. Punyasalila Srivastav, Dr. Jairaj Pandian, President, World Stroke Organization and Professor and Head of Neurology, Principal and Dean, Christian Medical College, Ludhiana, Dr. Harsh Mahajan, Chairman, FICCI Health Services, Founder and Chairman, Mahajan Imaging and Labs, Mr. Mandip Singh Kumar, Vice President and Managing Director of India Meditronics Private Limited, all distinguished guests, government experts, as well as all neurologists, neurosurgeons, and persons from the FICCIs, brothers and sisters. Now, it's a great honor and privilege to be here today at the National Stroke Summit. This platform, which is bringing all experts, clinicians, researchers, and policymakers dedicated to addressing one of the most pressing challenge in the health services. Now, our constitution definitely has given the right to the health, right to the life as a fundamental right for every citizen. Our government, under the able leadership of Honorable Prime Minister Narendra Modi ji, as well as Health Ministry under the leadership of Honorable J.P. Nadda ji, has given the top priority to the health. Now, everyone might have noticed that more than the 2% of the GDP is spent on the health from the last year. And in this financial budget also, Secretary Ma'am will definitely agree that more GDP, more percentage from the GDP will be given to the health services. Now you all know that these health facilities should reach to the periphery, to the poorest of the poor, who is deprived of the health services. And that's why Honorable Prime Minister has designed Ayushman Bharat Digital Health Mission, Prime Minister's Ayushman Bharat. And because of this Ayushman Bharat health structure, even the cardiac intervention, stroke intervention is possible. Even all the state governments, they are having the schemes for this also. And this stroke is included. But there some changes are to be needed so that mechanical intervention as well as thrombolysis, those can be taken as a easy task. Because stroke, though it is having the higher mortality, it is the leading cause of the death, but it is having the most important thing is that which is preventable morbidity is there. We can prevent the morbidity. Because once the morbidity occurs, if the patient is having hemiplegia, he is having aphasia, then he has to bear the load, family has to bear the load. And even in the younger age, if the stroke happens, the total life is ruined. And that's why this preventable morbidity, all neurophysicians or interventional persons, they can definitely reduce the morbidity as well as mortality. Now, this burden has to be decreased. And that's why this World Stroke Forum or World Stroke Summit we have taken. This IMPF, that is Indian Medical Parliamentarian Forum. It is playing the role between all the research workers, all clinicians, and policymakers. Not only for this, but I am planning to have it for the epilepsy, it for the autism, because those are the most important problems the people are facing at large. Now in the stroke, what as a parliamentarian, as a people's representative, what I expect that when I was studying as an MBBS or MD, at that time, CT scan was also not there. We were depending on the only clinical material. But nowadays, we are having everything that CT angiography we can do the MRI, and even the timely intervention, we can prevent the morbidity. But whether we are able to give these services to the peripheral people, whether we are able to give the services to the poorest of the poor, that is the problem. And that's why I do agree with the Mr. Pandian that neurologists, number of the neurologists, one neurologist per million population. And that's why the intervention is not possible even at the district level, even at the district hospital. We have to run for the tertiary hospital, which is 200, 300 kilometers away. And that's why that golden period will get passed. Golden period of the 4.5 hour or 6 hour, that patient will not have that advantage. And that's why the policy, I am requesting the Ma'am Secretary of the Health Services and through them to the Honorable Minister also, that we have to promote, because we are more successful in cardiology to give the services to the people. And similarly, interventions in the stroke is also very important. And it should reach to the district hospital or to the sub-district hospital, at least to the district hospital. Thrombolysis can be done, or the differentiation between the hemorrhagic stroke and ischemic stroke can be done. And that's why for the larger level, because we are going to the Vikasit Bharat. In 2047, our Prime Minister has aimed that we are in the Vikasit Bharat. And in Vikasit Bharat, health is the most important priority for us, for the people. There should be no morbidity, especially in the working people. And that's why I expect that through this World Stroke Summit, we can have some change in the policy. We can have more suggestions from the experts, and we can make all these treatments affordable to the people, achievable to the people, and in the proper time. And with this expectation, I conclude myself. I thank all the organizers, especially FICCI, World Stroke Organization, and government, and Madam also consented to come here. And she has come here because she is the pillar of the health ministry. And she has come here, and that will be the way for the we can say the change in the policy in the stroke management or in the neurological management. I also thank all the experts, all the neurophysician, interventional person, neurosurgeons who has come here. They are very much distinguished person. Even Nitin is here. Nitin Dangi is also here because just now he has operated on the Saif Ali Khan. That he has also become the celebrity. So all distinguished doctors, they have come. I welcome you all, and we hope that we will direct towards the completion of the vision of our Prime Minister, Health for All by 2047. Thank you.
Thank you, sir, for your insightful address. Before we proceed, I am delighted to share that during this summit, we will be releasing two significant reports. So we will have a time to release these reports. Can we have them? I would now request our dignitaries on the dais to unveil the reports. The first report, the National Stroke Action Plan. This pivotal document aims to enhance the stroke care ecosystem by focusing on critical areas such as healthcare infrastructure, prevention, specialized therapies, and rehabilitation. It serves as a guiding framework for policymakers to reduce the stroke burden in India while aligning the NP-NCD programs initiatives for measurable and impactful outcomes. The second significant report is the stroke in India. It is just behind that at the back. The stroke in India, context and latest clinical evidence. The groundbreaking report highlights India's progress in generating local clinical evidence through the PRAN registry, a comprehensive multi-center study. It demonstrates the effectiveness and cost efficiency of mechanical thrombectomy for large vessel occlusion strokes in India, showcasing impressive outcomes with reduced disability and low mortality. These findings will play a crucial role in shaping health policies and alleviating the stroke burden nationwide. These reports underline the importance of data-driven approaches and collaborative efforts in transforming stroke care in India. And now we have come to the much-awaited inaugural address by the chief guest, Ms. Punya S. Srivastava. Ms. Srivastava is a distinguished Indian civil servant and the current Secretary of the Ministry of Health and Family Welfare, Government of India. She joined the Indian Administrative Service in 1993 and has held various pivotal roles, including Joint Secretary and Special Secretary in the Ministry of Home Affairs and Special Secretary in the Prime Minister's Office. She's an alumna of St. Stephen's College, University of Delhi, where she completed her graduation and post-graduation in physics. Ma'am, we are excited to hear what you have to say to us.
Respected Member of Parliament, Dr. Anil Sukhdev Rao Bondeji, Dr. Harsh Mahajan, Dr. Jairaj Pandian, Dr. Mandeep Singh Kumar, and all my esteemed colleagues and participants here. So very good morning to you. And I'm indeed privileged to be a part of this summit, and I'm grateful to Vicky for inviting me today. Stroke pe roke is a very powerful message. And I think that the presence of all of you here gives us the confidence that possibly we will be able to make more of a headway in this task. As mentioned by the previous participants, India is at a juncture where we have a double burden of both communicable as well as non-communicable diseases. So we need strategies for both. We have made considerable progress in controlling communicable diseases, and we are targeting one by one how to eliminate these from the country. But we also need to do the same for non-communicable diseases. As the previous, as the other speakers indicated, NCDs are the leading cause of death now, with 74% mortality globally and 66% mortality in our country. In fact, the NCDs outnumber all causes of mortality and morbidity, including the communicable diseases. And stroke, as I'm told, is one of the complications arising out of various NCDs, hypertension, diabetes, etc., and is therefore preventable to a large extent. So considering the burden which has been brought out by the experts before me, what is it that we can do is something that we have been discussing at various fora. Just a couple of weeks back, Dr. Swasti Charan is here. We all were in Hyderabad discussing with health secretaries and the mission directors of National Health Mission across the country how to strengthen the primary healthcare network for NCDs. And as Dr. Mahajan mentioned, very good examples, even for stroke prevention, came across in that workshop from various states. I can see many participants were there as well. Similarly, we had a Chief Secretary's conference in 2023 in which NCDs was a very important part of the discussion. Honorable Prime Minister sat through the entire Chief Secretary's conference, including the session on health. And various states have given commitments on how they will reduce NCDs in the country. So this is this thought of NCDs and stroke is of great importance before the government as well. A week or so back, I was discussing with Dr. Rajiv Behel, who is DG ICMR and Secretary Department of Health Research. He also shared the work that they are doing, as I think Dr. Mandeep mentioned about the stroke care pathways. So ICMR has also conducted studies to build stroke care pathways through stroke units in hospitals as well as mobile stroke units. They have such a project going on in Assam as well. And these details, of course, many of you might be aware, so I'm not going to repeat them. They are doing a multi-centric stroke study as well, and have come up with good Indian stroke clinical trial network. So these are all works in progress, and their phase 2 study is going on in various participating centers in the country. The India Hypertension Control Initiative is also playing an important role in our NP-NCD task, which we have set before ourselves. So why I was highlighting these examples is to show that government is very concerned about NCDs as well as stroke. And keeping in view the experiences, Government of India has undertaken the task to develop a robust hub and spoke model for stroke care. As many speakers said, that is what would be effective in the long run, because it will help us optimize the resources which we have before us, as also ensure equitable access to specialized treatment and rehabilitation services across the nation. The folder also highlights the revised stroke guidelines that have been issued by the ministry, and we are using these guidelines to actively strengthen the emergency care systems across the country, again, with a focus on improving access to timely stroke care. Currently, approximately 500 stroke units are operational, and we are committed to expand this network to ensure wider access to specialized care. The inputs which come forward today, my colleagues are here, though they will help us build into the next finance commission cycle. So as you are aware, we have a national health mission and an NP-NCD program. And now that we are going to develop it for the next financial cycle, we can build in more components which will help us handle these diseases in a more comprehensive way. So, as a respected member of parliament also brought out, these primary prevention strategies have been built in the national health programs. Ayushman Bharat, which is our umbrella scheme. As he mentioned, we have the we have the PMJ as a part of it, the Pradhan Mantri Jan Arogya Yojana, which has been discussed, but we also have the Ayushman Bharat Digital Mission as a part of it. We have the Ayushman Bharat Health Infrastructure Mission as a part of it. And we have the layer of Ayushman Arogya Mandir, which today we have over 175,000 such centers offering 12 packages, including NCDs across the country. We are building now on bringing these up to a certain national quality assurance standard. So it is here that the capacity building becomes very important. Government of India is also trying to strengthen the healthcare infrastructure by bringing in bigger investment in telemedicine, expanding the telemedicine services to improve access to stroke specialists in remote areas. We have capacity building going on, the public awareness campaign, research and innovation. All these aspects are building into us into our prevention of stroke strategy. In fact, one of my colleagues who mentioned about strengthening the community health centers, I think that is also a very important part. And as I traveled across the country, I found some very good work being done in this regard by by building the capacity at the CHCs. PHCs identify, and if the first referral unit CHC is strengthened, through small interventions, you can make a big change. As also brought out by a respected member of parliament, the increased prevalence of stroke is a consequence of the changes that we are seeing in our lifestyle. And therefore, the best buys are in health promotion, prevention, and adherence to treatment once you are diagnosed with any of the NCDs, so that grave consequences like stroke can be avoided. So I really look forward to the deliberations today, because it's very difficult to have such an eminent gathering at one place. And I would really appreciate if we can get the feedback so that we build it into our program strategies. I also really like the documents you brought out, because they're simple, clear, and brief. I mean, so it's very good informational material also. There is another thing which I can never resist when I'm in any gathering. I know it's not related to the topic, but I'd still like to mention, as you are aware, this year the target for us is to work towards elimination of TB. And since you all are leading practitioners in the field of health and medicine, I would just like to apprise you that we have an intensified TB elimination 100 days program going on. Of course, we'll need to continue it further. And as a part of this intensified program, we have identified 347 high burden prioritized districts across the country. And even 250 members of parliament participated in a workshop, a session, a meeting that we held on the National TB Elimination Program. And I know I shouldn't take your time too much, but since Vicky is also here, I would like to really request your support, because you have a vast network. So if you can generate the awareness, all that we need from all of you is to develop awareness about it. And those of you who can become Nikshay Mitra or in any other way support the program, we would be very happy we would be very grateful for your cooperation. I will also request Vicky to organize a separate session on the TB elimination program also, because this is something that we cannot eliminate unless we all come together. So that was just an aside because I couldn't resist the temptation. But as Sir mentioned, there are very eminent personalities from across the country here. Your insights and experiences will be invaluable in guiding our efforts to improve stroke care. And together, I'm sure we can make a deep impact on all the people in our country. And I thank you again for inviting me here, Jai Hind.
Thank you, ma'am, for your valuable inputs, and we look forward to being guided by you as we take forward the summit agenda. And now I would like to request Mr. Ravi Valia, Member, FICCI Medical Devices Committee, Director, Government Affairs, Market Access, Government Tenders, and GEM India Medtronics Private Limited, to conclude the proceedings of inaugural session and present the vote of thanks.
Good morning, everyone. It is a privilege and honor for me to stand before such an esteemed gathering today at the National Stroke Summit 2025. First and foremost, I would like to thank a heartfelt gratitude to our Honorable Secretary, Ministry of Health and Family Welfare, Government of India, Ms. Punila Srivastava, for her inspiring leadership and steadfast commitment to improving healthcare in our nation, and stroke is certainly one of that. Your presence, ma'am, today here is a testament to the importance of this cause, and we deeply value your guidance. I'm also equally grateful to Honorable Member of Parliament and Chairperson of Indian Medical Parliamentarian Forum, Dr. Anil Bondeji. Sir, your unwavering support and dedication to advancing medical policies have been very instrumental in critical challenges. A special acknowledgement to Dr. Jairaj Pandian, sir, President W. World Stroke Organization, Professor and Head of Neurology and Principal, Dean of Christian Medical College, Ludhiana. Your exceptional expertise, sir, and global perspective continue to inspire advancements in the stroke care and prevention, and we are truly fortunate to have your insights shaping today's discussions. A big thank you to Harsh Mahajan, sir. You're always a guiding principle, and you'll always be the support whenever it's required from your side. I'm also grateful to Mandeep Singh Kumar, our Managing Director and Vice President, Medtronic, for his vision and guidance in driving the Medtronic mission in India and joining the fight against stroke. I would also like to thank all the distinguished officials from state governments, distinguished neurologists, neurosurgeons across the country for joining us today. Your contributions and collaborative efforts are certainly going to be vital for the success of our shared mission today. I'm also thankful to the officials of the Government of India, Ministry of Health and Welfare, for your time today. And of course, I would extend my appreciation to all the colleagues who are here today in this room for your time, your thoughts, and your unwavering support. Gathering here at the National Stroke Summit, we are addressing a topic of utmost importance, one that affects countless lives and demands our urgent attention. Strokes are not just a medical issue, they are a societal challenge and requiring collective action across innovation and policy reforms. As the panelists, as the inaugural session, everyone has talked about this, and the discussions which we'll have in the next few sessions are going to be playing a very pivotal role in shaping a future where stroke care and prevention are going to be more accessible and effective across all corners of the country, PHCs, CSCs, and what has been said. This summit is just not an event for us, but it's a symbol of our shared commitment for improving healthcare, outcomes, and saving lives. Thank you all for being a part of this journey together, for sharing your expertise, and for dedicating your energies to making a difference. Together, I'm confident we can bring about transformation change. Once again, my deepest gratitude to each one of you in this room. Let us continue this important work with renewed vigor and determination and make sure that stroke is also like diabetes and hypertension known to people in the world so that we can save lives and make difference today. Thank you very much.
Thank you, sir. I'd like for the dignitaries, along with Mr. Ravi, for a group photograph. On behalf of FICCI, I extend our heartfelt thanks to all the esteemed dignitaries for sharing their invaluable insights and guiding us towards actionable pathways. Your expertise and vision have set a strong foundation for the discussions ahead, and we are deeply grateful for your contributions. Thank you. Ladies and gentlemen, we plan to start the first session immediately, the panel discussion one. So I'd like for us to probably remain seated in, and we will begin in 5 minutes. Ladies and gentlemen, we will now begin the session. I would like to invite everyone back into the conference room. Ladies and gentlemen, we will now begin the session. I would like to invite everyone back into the conference room. Doctor? We are looking for Dr. B. Naresh. Dr. B. Naresh, can you please come over to the front? And Dr. Jacob. We're looking for Dr. Jacob. Dr. Jacob? Are you Dr. Jacob? May I request everyone to kindly be seated? We will now begin the session. Ladies and gentlemen, I kindly request you all to please be seated. Ladies and gentlemen, as we continue with today's program, it's time to dive into one of the most exciting and insightful parts of the summit, our panel discussions. This session, that is the first panel discussion, is designed to foster dialogue, exchange ideas, and uncover actionable solutions for enhancing stroke care in India. I would like to invite our panelists and our dignitaries to the dais. Dr. Harsh Mahajan, Chair, FICCI Health Services Committee and founder and chairman, Mahajan Imaging Labs. Dr. L. Swasticharan, additional DDG and director, EMR, Ministry of Health and Family Welfare, Government of India. Dr. P.N. Sailaja, professor and head of neurology, Sri Chitra Tirunal Institute for Medical Sciences and Technology, Trivandrum, Kerala. Dr. Gaurav Goel, Director and Head, Neurology, Medanta. I'd like to invite the dignitaries over to the dais. Please. I'd also like to call upon our panelists towards the dais. Dr. Shailesh Gaikwad, Chief of Neurosciences Center, Professor and Head of Department of Neuroimaging and Interventional Neuroradiology, AIMS in New Delhi. Dr. Nitin Ndange, Comprehensive Stroke and Endovascular Neurosurgeon, Lilavati and Sion Hospital, Mumbai. Dr. Ajay Kumar, Professor, Neuroimaging and Interventional Neuroradiology, Department of Radiodiagnosis and Imaging, PGIMER in Chandigarh, and Dr. Tariq Matin, Director-in-Chief, Neurointerventional Surgery, Artemis Hospitals. These are our esteemed panelists for this day. And at this time, I would like to hand over this panel discussion to our moderator, Dr. P.N. Sailaja, Professor and Head of Neurology, Sri Chitra Tirunal Institute for Medical Sciences and Technology, Trivandrum. Ma'am, over to you.
Thank you. First of all, thanks to FICCI and the World Stroke Organization and the Medtronic and the Member of Parliamentarians Forum for this initiative. It's in fact a great initiative so that we'll have some action plan for stroke and reducing the stroke burden in India. So currently we have in our panel distinguished stroke neurologist, interventionalist, policymakers, and the team of people who will be driving the stroke care in India. So in this session, what we have is we are going to have a discussion on what are the gaps with regard to stroke care in India, and what are the ways in which you can have suggestions and insightful discussion on how to transform the outcomes of stroke for India. And this may be points in which we'll be making up the action plan, which Dr. Jairaj Pandian from the World Stroke Organization has mentioned. And in this 2025 National Stroke Summit, we will have at least a few of the action plans which can be taken up for the next 1 year. So coming to the context of this, we know that stroke is a leading cause of death and disability. And if you look at India, which Dr. Jairaj has already highlighted on, and also all the previous speakers have highlighted, is with regard to about 120 to 140 per 100,000 is the stroke incidence. And if you look at the 1 month mortality, it extends from 20 to 40% in a month. So the important barriers, if you look into with regard to stroke care, is starting from the delayed arrival of the patients to the hospital. Second is with regard to the lack of access. That means lack of enough stroke care units, both primary and comprehensive stroke care units. Third is with regard to having more and more infrastructure with available facilities. And next is with regard to the availability of more of interventionalists and stroke neurologists to manage these patients. And one of the major challenges with regard to the financial barriers and coming to the lack of the rehabilitation centers in India. In this session, we will be mostly concentrating on what are the important gaps, which will be mostly looking at the acute stroke care and also with regard to the emergency, wherein there is a delayed arrival of the patients. And then we'll go on to ask each of the distinguished panelists with regard to what are their suggestions by which we can improve upon the outcomes of these patients. So to start with, I would just like to ask Dr. Harsh Mahajan, whom we all know is actually a pioneer in AI and in imaging, and I think his insightful thoughts with regard to this will make a real impact. And I would like to ask Dr. Harsh Mahajan with regard to just briefly talk about what is the evolution of stroke care in India in the last few years.
Thank you very much. It's an honor to be amongst this eminent panel. And what I would say that if we go back and, it was 40 years ago that I started my MD in radiology. And except for All India Institute, which did have a CT scanner at that time, no one else. I was at PGI Chandigarh, we didn't have a CT scanner. There was one outside, which we used to send patients to. Today, if we see, not only CT, but MR is present across the country. All the major institutions have it. In the periphery, also, in private, they are present all over. The problem is that even now, in the rural areas, patients will have to travel 200, 300, 400 kilometers to access one. And that's where the problem lies. So CT, we know for stroke is the initial modality that is to be used. Even if MR is not there, it doesn't matter. We rule out hemorrhagic stroke, that's good enough, and we go. So this hub and spoke model, which we've been talking about for 30 years, it hasn't come into being on the ground. It has still been on paper. And ultimately, I think time has come now that if we are to be a $5 trillion economy, we have to have a healthy India. It just can't be otherwise. Also, I would say that our focus, especially when we look at the government and when the government buys the equipment, the focus is always to buy the best, the most expensive, because the feeling is this is the one opportunity that we'll get. And whereas in the cost of that best equipment, we may be able to buy 4, which will do a good enough job. I mean, there is this Indian professor at Harvard Business School who talks about good enough technology. I mean, it needn't be the cutting edge. Of course, All India Institute will require the cutting edge. Centers of eminence will require that, but in our district hospitals, a 16-slice CT would suffice. Similarly, we don't need a 3 Tesla MR. Even if we talk of MR, we in Delhi put up a MR in 1991, which came 2 years before All India Institute. So please don't disregard the private sector also. And this trust deficit, which has been there for a long, long time, which somehow during COVID, just disappeared. We worked hand in hand. So we showed that we can work together. But having said that, I think on the government side, one has to realize that the private sector has to be viable. I don't say you profiteer. You make a certain profit to keep yourself viable and sustainable. And that's where the public-private partnerships, and we've done 2 of them, we've lost money in both. One of them still runs in Delhi. It's been 14 years. And so a viable public-private partnership would bring in much more of the private sector. Of course, I'm talking at a much wider level, not just to do with stroke or things. So I feel that unless we bridge the trust deficit between public and private, and unless we can work hand in hand, we will not find enough resources to reach the last man in the line and to reach the peripheral parts of our country, and also to reach the poor in our cities. Even they lack healthcare. The Ayushman Bharat scheme is a step in the right direction, but there again, I would say it has to be viable. If it costs a hospital, including a public hospital, 50,000 rupees to give a treatment, and the reimbursement is 15,000, it's just not going to work. And that's where we have to all sit together and find a solution. Thank you very much.
Thank you, Dr. Mahajan, for the very important points of relevance and what are the things which are lacking and what are the barriers. And I will come to you, to each of the panelists with regard to the specific areas of discussion. But before we go on to the panel discussion, I would just like Dr. Swasthicharan to just say a few words with regard to this stroke care.
Thank you, ma'am, and dignitaries on the dais. It's indeed a pleasure to be here. And it was wonderful to hear our Health Secretary, Madam, leading from the front. And we all are geared up for a very good deliberation today. Now, for me, as a DDG in the Ministry of Health, looking after various programs, I do also look after some of the risk factors of the NCD. So I want to see it as a whole spectrum, not starting when the stroke happened, but long before a stroke or any of those NCDs happening. So we need to have what is known as the whole of government or the whole of society approach right from the risk factors onward. Because if we keep trying to treat or manage we still have to manage. I'm not saying that we are not supposed to manage them. That is, to me, like for a public health person, it's like we have a tap on in one corner of the room, and then we are trying to mop clean the floor of that room. So we need to close the tap together. That's my first remark. Second thing is sometimes many of the health issues are beyond health. So we need to have what is known as the multi-sectoral collaboration. For that, we have what is known as National Multi-Sectoral Action Plan of India, and this provides us a platform where we interact and where we integrate with other ministries, say, for example, Ministry of Youth Affairs and Sports, FASAI. We also interact with the Ministry of Education, etc. Because whenever we want to do any health promotion or health prevention, we have to crisscross to many ministries and work together with them. So we are revising the National Multi-Sectoral Action Plan of India, and there we will also try to see where particularly the stroke component is also figured there. You have all heard madams speaking, trying to establish the stroke care units across the country. To me, sometimes I wonder that whenever I hear an ambulance in the road, or you meet an ambulance on the way, then I know how precious that time is. I also had one of the units in the ministry called emergency medical relief. So we are used to health sector disaster management, and then we know that important. Then at the same time, my other portfolio of NCDs, the non-communicable diseases, and the risk factors, the number of years that we had wasted, in terms of tobacco, alcohol, and physical inactivity, etc. And suddenly you have a health catastrophe, be it stroke or a cardiac issue, then suddenly the time become very precious. So, and then we all in the health sector, the system tries to figure out where we will establish the best centers, where we will have what is known as the pre-hospital system, the right ambulance coming at the right time, taking to the right hospital where the right, treating doctor with the right capacity is going to treat you within the time frame, so that your nerve tissue, the nerve tissue or the cardiac muscle is saved. So that kind of holistic approach we need to do together. So today's workshop, we should also be focusing on how we should be dealing with holistically, and also try to use examples of stroke cases, cardiac cases, so that we do advocacy to the other extreme of the age, when we are experimenting when we are trying to initiate some of the risk factors like tobacco. So 1.4 billion population, if you cut across, we will see many patients. If Dr. Pania was saying every 40 seconds somebody is going to have a stroke. So if you freeze time for some time, someone is going to have a stroke. Someone at the same time is going to initiate tobacco use in some part of the country. So all these to me are related. So we all do have to do this advocacy together, try to prevent the generation from not initiating tobacco use or alcohol, and also actively engaging in physical activity. And that in that 1.4 billion people, there would be many who are already having one of the diseases or NCDs like hypertension or cardiovascular diseases or diabetes, but they are roaming around because they don't come to the screening. So we need to do them also. So this holistic approach is what we look at in the ministry, and we have various programs, components of the national program for the NCDs, and we'll be working together in that. As ma'am has already rightly said, we are revising the national stroke guidelines, and we would like to have inputs from stalwarts here so that we have the right, guideline for the medical officer who is going to treat, or the state nodal officer who is going to help establish, the stroke. And Dr. Bipin is here. I'm sure if you read the current stroke guidelines, it's very technical. Then, as a public health fellow, I'll read the initial pages. I won't understand anything, and then I won't look beyond the initial chapters. Which deals with establishing stroke units. So Dr. Kameshwar Prasad, Andian is here. They are helping us to develop the right guidelines for us. We need to establish the stroke units. We need to integrate with the emergency medical service. And I'm happy that Madam Secretary mentioned about the ICMR project, and we are working on that, on an operational research and to find out what is the best stroke system that we should have. We should have the right ambulance, the right call center like 108 and the EMRI and etc., which will help link all the areas of stroke management. And as I said, please help us also prevent. Please help us also manage, and then we'll have a holistic approach. And the ministry is with each one of you, and we are all open to discussions. I'm happy that Madam came here for leading us from the front, and we will follow the directions from Madam from time to time and integrate whatever is required for this country. And I'm happy that the action plan has come. Then in my mind, I was thinking I'll discuss with the experts again whether we can. I was talking to Madam whether we can examine every state with the lens of what is being produced today and see if that particular state is stroke ready or not in terms of prevention, in terms of the pre-hospital care that the particular state could be having, or the management facilities and the manpower which is available in that state. And then we try to see if there is a gap, and then try to build that gap together, be it in private sector or be it in public sector. This is my first take after listening to some of you in the beginning, and I'm happy to be here with us. Thank you for inviting me.
Thank you, Dr. Swasti Charan. Those were all very important points with regard to the stroke care. And I think along with this, I would just like to mention that we recently did a geospatial mapping of the whole of the country, which I think, since you have mentioned about the areas we need to identify, which are the states which are having a gap. Actually, from that analysis, which was just published in the International Journal of Stroke, myself, Dr. Jairaj, Dr. Dheeraj, we are all part of that study, and it was done by the stroke program, which the Achyuta Menon Center for Public Health, and it took 1.5 years of work mapping out all these states. And what we found was that we had around 566 IBT centers and 360 intervention centers. And the most important information was South and West was the most areas which were more stroke ready compared to the North. And the Northeast was the area which has got a significant lack. And another important information that within 1 hour, if you look at the national level, a patient is able to reach a hospital within 1 hour is only 26% of the population, which is a huge gap. And if you compare the south with the northeast, you find that in the south, you can see that a good number of these patients are able to reach within 1 hour, and the mean time to reach a IVT or a EVT center is within 1.8 hours. But if you look at northeast, it is between 6 to 8 hours. So there is a big gap, and this document actually is available online too, with all the supplementary material having the access to each of these centers, and that will be very helpful at a policy level to decide which are the areas we really need to work on with regard to comprehensive care centers and where hub and spoke model is going to be effective. So next, I would like to ask Dr. Gaurav. Dr. Gaurav, who is the director and head of interventional neurology from Medanta, and who was a leading part of the PRAN registry too, and who has been doing a lot of training activities for the young interventionalists in the country. If you can just briefly talk about evidence base with regard to stroke management in a few words.
So thank you, Dr. Shelja, for bringing that up. And I was asked to show some slides from the PRAN registry, which we all did together. And I think, as was said by Madam and all the other speakers in the morning, that, stroke constitutes a very devastating disease of NCDs and leading cause of, morbidity. So, yeah, all right, thank you. So, as we were discussing, the access to stroke care is not so good in our country. And if you look at the number for interventional IV thrombolysis, we are down to 0.41 per million population, the stroke centers which can give IV thrombolysis. And when it comes to mechanical thrombectomy, it's not even half of that. So at 0.26, and number of people who can actually do, we are talking said less than 1 per million, but that less than 1 is also at 0.15. And as Dr. Shelja was mentioning, that, if a patient has to reach to that center within 1 hour, for IV thrombolysis, it's accessible only to a 26% of the population. And when it comes to mechanical thrombectomy, it drops down to almost 20%. So there's a huge gap which we need to bridge. And with that background, the PRAN study was conducted for 200 patients at 14 different sites, and again, more towards south and west than towards the north. And 200 patients were enrolled, and 190 were actually treated by mechanical thrombectomy over a period of 2 years. And what was important is we are trying to highlight that this treatment, though has been shown that it works in the Western world, is it true in the Indian subsetting? And that's what was the purpose of doing this study for large vessel occlusion, which causes stroke. And hopefully, since we have the report released and the data is there in your hands now, maybe, we can all sit together and design the policies of how to make the adoption better by using these data. So the numbers were very impressive, and when treated, and the time metrics, within the time metrics, these good functional outcome was of more than 65% of the patients MRS score of 0 to 2, which means they can get back to their normal work. Almost 80% of the patients were discharged home, and the safety metrics, the mortality reduced to 6.3%. So it's an important data which comes out from the 14 different centers. And if you look at how this compared to all the randomized control trial data, which kick-started the stroke process, the treatment which we are doing today, and the number is comparable and in certain metrics better, because over a period of time, the techniques have got refined. We understand where to do, where not to do. And the good clinical outcome and the technical success of these procedures is at par with the global excellence. And we are highlighting the challenges that, we do not have access to all the centers, and there's shortage of personnel. But despite that, when done properly, when done at the right centers, the therapeutic effect of the modality is for all of us to see. So I think it's very important to bring out this data from the country, and I think this should shape our policy since all of us are here. It should help with that.
Thank you, Dr. Gaurav, for that information with regard to the PRAN study. And I think at this point of time, I would like to congratulate and thank the Medtronic and the team for funding this study, and because we never had this kind of a prospective data. And as Dr. Gaurav has rightly pointed out, showing that if you have a patient to come to a center with the facilities available, and we were able to show that by doing endovascular thrombectomy, you can have the same results as what has been shown globally. And if you have the right patient, the outcome is going to be 50% of them, 40 to 50% of them are going to be functionally independent at 3 months, which is something of a great impact when it comes to the stroke burden. And not only that, another important thing about that study, which we are planning to publish in the next 1 or 2 months, is the cost effectiveness. So if you are giving this treatment, it is cost, even though it is expensive, it really makes a difference with regard to the cost. And I think once that the document comes out, I think that will be an additional document from a policy level to have more and more endovascular centers and also more and more interventionalists, because the major point is that we don't have enough interventionalists, especially in Tamil Nadu. They have got centers, they have cath labs established, but there are no interventionalists to do the procedure who are trained. So I think that is also another thing from a policy level. We should have short kind of programs or proctorship programs, which should be started at a national level to have neurologists, neurosurgeons, and radiologists to do this procedure, so that is the only way we can bridge the gap of having professionals working in this area. So the next question which I would like to ask is to Dr. Harsh Mahajan again. You mentioned about there is definitely a delay in the early arrival of the patients. What are the key 2-3 points which you would say in which India at a policy level and also from a professional level from the doctors, how can we improve upon patients reaching the hospital as early as possible so that they get the time-sensitive revascularization treatment?
I think awareness is the most important part, both for citizens at large as well as for physicians. Recognizing a fact that if there's some tingling happening in the fingers or some little weakness, to recognize that that may be the harbinger of a larger stroke, that is something which, at least at the physician level, needs to be brought home. So education, awareness, I think that is the first step. To begin with, maybe in the medical community at large, and at the same time through these some celebrities talking about it on television, on social media. I think especially social media, the influencers, they have a lot of impact. After that, then it is, suppose I even know that something is happening, how do I reach a hospital? And so the ambulance services, that I think is the next best. And also ambulance services, which may not be cardiac ambulances, but if there's a technician who can actually, even giving an aspirin or something. Hemorrhagic stroke, we know, is only 10% of all strokes. 90% are ischemic strokes. Aspirin will not actually adversely impact in that case. That being given, maybe some statin somewhere, just as somehow I think we need to learn from the cardiologists. Someone has a shooting pain in the foot. The first thing he thinks is, "Oh, मेरे को heart attack तो नहीं हो रहा है." So they are very, very good sales and marketing people. We need to learn from them, at least not do anything untoward. But with that, I think, of course, we had Flipkart. No, it wasn't Flipkart. Blinkit. Saying that they will, provide an ambulance within 10 minutes. I hope that is not just a dream, that it can be reality. But even if it becomes a reality in some parts of the country, even that will be very useful. And then, of course, the establishment of the hub and spoke model, the spoke where today, uh, a spoke which has a CT scan where that, and if possible, a CT angio being possible at the spoke level. And then based on that, through a digital tool, AI-based diagnosis, being sent to a neurologist or a neurointerventionalist or a radiologist at the same time, where on their handheld device, the phone, they're able to make out what it is with a AI report. And this is a reality. There are commercially available algorithms which can do this. And then based on that, the neurologist takes a call as to whether the patient can be treated at the spoke or needs to be rushed to the hub. This, I think, is something which is not just, something we are imagining. It is something which is possible. And then training of personnel, maybe at the district hospital level, and then the medical colleges and the tertiary care centers could become the hub, and the spokes are the district hospitals to begin with. Hopefully, they will become hubs and have spokes as we go down 2 years, 4 years, 5 years down the line. I think that is very necessary. And also, I think in the books that we have in schools, fifth, sixth, seventh, eighth, why not have a chapter on NCDs, in easy language, so that the kids can actually go and teach their parents, and the parents always read those books. So that could be another way, a simple way, one small chapter, and it would be very useful.
I think very, very important points. I would just like to tell the points which have been highlighted. One is with regard to the training, which should be there at the level of the physicians, neurologists. Even physicians never treat the patients on time because they do not know the importance of this time-sensitive treatment. Hub and spoke model, very, very important, especially there are a lot of areas where there is no access. Celebrities, I think each of us who have got a passion for stroke care should have some celebrity. I was just talking to Dr. Nitin that you should have Saif Ali Khan to talk about stroke, and you should use it very effectively. And I think school education, I think, becomes very, very important because there have been a lot of videos shown from the China and Korea showing the grandson recognizing a stroke and calling the EMS. So I think it has got, even if it is a 5% impact, it really have an impact. And national level of, I think, TV, because many of the Canadian and all, you find that TVs announce actually brief videos, which can be done at governmental level, having these kind of videos to be shown. So the next question is again to Dr. Sathyacharan. After that, we're going to be the panel. One is with regard to the Ayushman Bharat. We know that Ayushman Bharat has significantly made an impact with regard to implementation of these healthcare packages. But we always talk about the private hospitals are not able to take it up because still the packages are not come to the level where the private hospitals, and we know that 60% of these stroke care is happening still in the private setups, and especially endovascular thrombectomy. So what are the plans from a policy level where we can see that these packages can make an impact with regard to the stroke care, both at the medical colleges and also because I am in a Sri Chitra Institute, even if it is a center of national importance, we also can take up only the patients who come with a CASP or a governmental insurance card. Rest of the patients are not able to afford, even though our cost of the endovascular treatment is still within 3 lakhs. So I would just like to hear from you over the next 1 or 2 years, what are the plans in the Ayushman Bharat?
First of all, it's a very important question, but you are asking the wrong person. I don't deal with PMJ, but I am sure what happens is we have Rashtriya Roganidhi, then PMJ. These are common, what we call the water holes in the jungle with all the diseases, trying to get that packages. So that's the first thing. So we need to have priorities also. We need to have priorities among all the health conditions or the diseases or the priorities of the packages. So that we need to build along the way. That's what I said in the beginning also. Stroke, we have started talking about stroke, but it was only within some community. Now we have become a bigger community and we need to do it at the national level. And then, as Dr. Mahajan has rightly pointed out, they have to spell out that this is not happening because of this situation. And then I think our colleagues who are looking after PMJ, they can also have a look and then see how we can improve that. The fact that the PMJ is there, the government's intention is already clear, and then the nitty-gritties can always be looked into by those people who are looking at that. And then that to me is one aspect. We need to cater to that. The other aspect is the medical officers, training of the medical officers that we should be doing so that we don't have much population reaching to that. I also look after some diseases called rare diseases, and rare disease, the package is 50 lakhs. That's a 50 lakhs. So then if you have many rare diseases and we are trying to cater all of them, then 50 lakh is a big amount and we are not able to do it. And with all this 50 lakh, which I think is very big, there are some diseases like spinal muscular atrophy, which requires 16 crore. Then I'm not able to do anything for that. So that kind of challenge will always happen, and that happens with PMJ also, I suppose. That is why we have this, and I think it should be discussed open. Coming back to the medical officers training, what I see from the field is many of our colleagues who work in the field, they will also see that we need to build that capacity. We need to build that confidence in the medical officers in working in the primary health center, community health center, or the district hospital. District hospital has got some specialties also, because when we once somebody decides that I'll work in a in a primary health center, I say I'm okay with primary health care. I do immunization. I'll be the TB officer. If you come today and ask me who is the TB officer, I'll identify myself as the TB officer. Then next day if I go that I'm from the same program for NCD, who is the person looking after NCD? He will identify again as the NCD officer. It's the same person. And then he does delivery also. He does immunization also. There are so many roles that he plays. Then whenever he has a catastrophe like stroke, the first instinct he will have is, I should refer this particular patient to the nearest center possible, which would be very far off, but he won't take a risk. So we need to build the confidence in him that if you do this intervention now, and doing this intervention is not that difficult, and we are there to protect you. The system should be able to protect you if any error happens because of diagnosis or therapy. That confidence I find is missing in the medical officer working at the primary health center or the community health center. And so once we build that, then the comprehensive care, which Dr. Mahajan was saying, could happen. So that happens along the way. We should build it along the way. I think, and that's how we should proceed now.
Thank you, Dr. Susticharan, for those points. I would just like to now go to Dr. Shailesh Kevkwar with his intervention list, and he has been one of the main centers where maximum thrombectomies are happening in India, and has been involved in training so many young interventionalists for the country. And we have already talked about Ayushman Bharat being in AIIMS Delhi. It may be much easier to do endovascular thrombectomy because cost doesn't come as a major issue. But still, what are the challenges? We know that it has become a real great treatment where if a patient is coming to you with a large vessel occlusion and you are able to do endovascular thrombectomy, have you had any limitations being in a public sector with regard to offering the treatment to the patients? What are all the barriers you face other than the financial also? And what do you think about its impact? Because there are a lot of there are private centers which are doing thrombectomy. And what are the limitations from the comparison between the public and the private with regard to all this expensive treatment?
Thank you, madam, for asking that question, and thank you for having me here. I will say that I was part of the first Ayushman Bharat scheme, and there I devised a package, but was given a limit of 5 lakhs. Within those 5 lakhs, I have to devise a package which is affordable to most. So unfortunately, what happened, many private sector didn't participate then. When the second time a chance was given to me, I decided to revise it and upscale the cost of the treatment so that more and more private center gets into the treatment fold and they start offering the treatment, because it's not possible to cater to the huge burden of stroke at one center like AIMS or other stroke ready centers across Delhi or the NCR. So fortunately for AIMS, I think the package system of Ayushman Bharat scheme is working quite well. But the challenges are there. The challenges are getting endorsement. There is something called endorsement. We have to get it endorsed from the Ayushman Bharat scheme operator, who takes a bit time. So then I realized that if the endorsement doesn't come within that time limit, 3 hours, 6 hours, the outcome will definitely, I think, go down. So my intention is to intervene as early as possible without waiting for endorsement from anyone. If the stroke neurologist has identified that this is a stroke, if you have done a CT, we have ruled out hemorrhage, we have done a large vessel, we have identified this a large vessel occlusion by straight away going for a CT angiogram, then the next step is to go inside the angio lab, remove the clot. Whether bridging is given or not given is, I think, will depend upon the eligibility criteria. So the pathway in my center is as soon as the patient goes to the ER, the stroke neurologist gets the call and everybody gets, I think, warning that a stroke patient is lying in the casualty and we should be rushing to the center. So after the ER, the patient comes straight to the CT room. It gets evaluated by the neurologist in the CT room. It's not in the emergency room. So we do a CT, angiogram, and once we identify that this is a large vessel occlusion, IV TPA is given right there in the CT room. And the next step is to take inside the angio suite, remove the clot. I generally prefer mechanical thrombectomy. Sometimes I do a hybrid technique like aspiration, stent retriever, or combination of both. But there are challenges like because of this so-called Make in India concept, the availability of the devices, because they don't fall under the Make in India exemption. So this is one major challenges. I have taken this matter to the government of India and requested them for the time being till this Make in India becomes a success. We should give them an exemption and we should procure more and more devices which are right now tested, proven, and they are FDA approved so that we can do and remove the clot. So that is still ongoing right now. But in my opinion, the challenge still lies in intervening the patient with acute stroke in a timely manner. If you intervene within 1 hour, I think the outcome will be much better than you intervene 6 hours. And now we have trials where we can go and treat up to 24 hours. But what is the point? Because the rate of improvement or the outcome will go down subsequently because more and more neurons keep time. So in my opinion, the first thing is to treat as early as possible. Then, of course, around the periphery of the Delhi or centers where this stroke interventionist is not available, the interventional neuroradiologists or interventionists are not available, we have to work on the strengthening of the hub and spoke kind of a model. It has been talked about for a long time, but still it has not penetrated. Sorry to say that, but I think the government and the policymakers should focus on this. Then the availability of a trained manpower, right? So my objective is to start training the medical college level. If you look at the MD radiology or MD medicine, we don't have awareness about this stroke. That is the saddest part. And I think we should have a neurosciences center in every medical colleges where entire disciplines of the neurosciences center, starting from neurology, neurosurgeon, neurointerventionist, neuroanesthetists, and of course, the rehabilitation is part of that team. So we should start training doctors from the medical college level so that the awareness goes up. And as they spread out, I think this will help on capacity building also. So lack of trained manpower is one major challenge, I think, apart from the cost and affordability. Affordability, of course, Ayushman Bharat has played a major role, but still, I think, in my opinion, when you are looking for the endorsement take a time. So I took a proposal to the government saying all acute stroke intervention should be exempted. should be made free of cost, whether it's a rich person or a poor person. But that was, of course, not accepted. So I think one should focus in that direction rather than I getting and asking the other agencies to endorse it. I think we should be in a driving position to take a call right on table, because there's a clot, we have to remove it. Why should I wait for endorsement? It takes a lot of time. So that is one thing, ma'am. And of course, awareness that this is a stroke. Of course, awareness is coming now because of the impact of the social media, the TV, the videos, and everybody has to work together. And I agree with Dr. Harsh Mahajan, there has to be a private-public partnership, because private also plays a major role. Almost, I think, 60 to 70% of the healthcare need is catered by the private sector. And government sector, I think my take on this forum is that we should have a properly trained training courses like DM courses or a DNB courses in a relevant field, so that we have a properly trained manpower who will minimize the complication. Of course, when you intervene, also you create complication. That complication part should be minimized. So anything apart from this, I'm more than willing to answer. Thank you for that.
Thank you, Professor Gaikwad. I think very important points which has been highlighted. But I would say that even with all the training being given, we have very few limited seats for radiologists and neurologists to get trained. And also the fellowship program is also very less. So from the intervention community, I think we should have short courses or 1-year programs, because we have more neurologists than radiologists in India. And we should have all the neurologists, at least more of fellowship programs wherein they can be trained. I think that's the only way we can improve upon having more
Madam,
and more
whatever is the training program, whether it's a fellowship program or DNB program or a DM program, there has to be a training program and a focused training program.
Yes, I think totally agree. So now over to Dr. Nitin Danke. And I think about a few years back, Maharashtra was one state which had the least stroke units in the governmental setup. And that is the area where there was a big gap. When Kerala, we were having even stroke units in the district hospitals, primary stroke care units in the district hospitals. And Dr. Danke was mostly involved in starting the first stroke care units in the state, in the government setups. I would just like to ask you what were the initiative and to what level you have made a difference, and what are the challenges, and what is your way forward with regard to having more and more stroke units in the governmental setup, because that is the area, that is the only way we can have more patients to receive the treatment.
So good afternoon, everybody, respected dignitaries on the dais and the esteemed guests, friends, and all those all gathered here. It's really an honor and privilege to be here amongst this gathering today and sharing my thought processes, which I think so stroke is my passion. And since I took training from Japan for endovascular after my neurosurgery in 2010, I had lots of hopes and dedication towards difference making in stroke care. So when we came back, that time the studies and the trials were not there for mechanical thrombectomy. It was mainly thrombolysis, IVT in India and our centers. But I had another privilege of working in public and private sector, because Mumbai allows private practice being in municipal hospitals. So I face and I've experienced and exposed to both strata of population. That gave me thought process of what are the basic problems in the public sector, which majority of the time I was pairing and treating patients. So having exposed to these problems, we realized for me to get a biplane cath lab and develop a comprehensive stroke care center to a tertiary institute like KM, it took me almost 10 years. Okay, so such was the lacuna and the zeal, or there was no sensitivity about this disease by the public sector, by the, I would say, the administration. I had to take multiple meetings, conduct them, uh, make them aware about the disease. And still, I feel there's very minimal sensitivity amongst the policy makers. Why? I'll tell you. The burden what we are talking today is hardly anything because we don't have data. We have very well less data which we are having about stroke patients in the, whatever data is so huge. And I don't understand why the policy makers don't take this as a life-saving disease. Like the cardiac and stroke, these are the two things which should be taken as a life-saving disease among the NCD. Okay, this is a very important message I want to give here, because this is the right platform. I feel that it's not to be compared with other non-communicable diseases. Please understand, this is a very deadly disease, a disability in the population which is so significant after a stroke. You cannot compare the financial burden the person is going to have, the family is going to have, as well as the country as a whole, losing the working hours of the person who has suffered. So having said so, when we sensitize, I started the stroke unit in 2019 as a comprehensive. Why I added this as a comprehensive? Because earlier our dean, Rawat madam, was a neurologist who was taking care of stroke care. We had a stroke team there, but introducing the new technology and getting into a high technology unit into a public sector was my main aim, was to make awareness that stroke can be treated, it can be cured, time is essential. So we brought that center, we inaugurated in a big way, in such a big way that the social media made that during 2019 onwards, it became such an impactful message to all of the state, Maharashtra, that that message was made in a very odd way, spreading even today, that this machine is doing brain tumors and all those things. But it was mainly for stroke care, whether it is ischemic or hemorrhagic, but mainly for hemorrhagic stroke care. And I used to go at midnight. Even today, we formed a team, but I had passion that at midnight also, if a senior is coming, a professor is coming and doing a thrombectomy, obviously your fellows, your students, they have that passion, they get sensitized, and that's how awareness was created. Of course, WhatsApp, social media was completely a boon for us for spreading this awareness. But it's not only the thing which is more important for awareness. The basic problem which I feel of what we are talking of awareness has a little different impact on the patient who is suffering from what we call stroke. It's not the patient who is getting is aware of the problem. Unfortunately, it is the near and dear ones, the friends, family has to be sensitized. This is the basic problem which I feel is the cause of delay in presenting to the hospital. Like the MI patient, he himself suffers pain. He feels that he is dying. He rushes to her. I'm giving a very recent example how the person who is suffering as well as the presence of mind matters. Just a recent example, I'll say. At 2 o'clock, a VVIP, a Bollywood celebrity, was attacked at his home, in his bedroom, by a theft, robber or whatever. He was stabbed in his back, and he comes down. He has access to everything, an ambulance, his cars, uh, drivers, everything. But he's thought that getting all these things organized in that time was way much time consuming. Instead, he called an auto which was standing just beside his house, and he reached to the hospital because of presence of mind, his awareness, the nearby hospital, which was Leelavati. And that was at midnight, 2:30 a.m. So he didn't wait for calling an ambulance. Whatever way we can reduce the time to reach to the hospital after you are aware, means this is very, very important for the population to make aware that somebody is suffering from stroke symptoms. We need to take him to the nearby stroke radio hospital. So coming back to the awareness about timely reaching, reducing to door to hospital time is very, very crucial. That can be impactful. I again say we call Bollywood celebrities, we felicitate every stroke, World Stroke Day every year. I do that in all the hospitals in Mumbai. I call celebrities, I felicitate the stroke survivors who have come in time, and those are our stroke ambassadors who go into the society and say that stroke can be treated, cured if you reach in time. So this is the way we have started our this thing. Whole Maharashtra is aware of what is 24 hours golden window time for mechanical thrombectomy today at least. And I'm proud to say that because of we started it in the municipal hospitals, which is a public sector, what you call source, and that made a huge impact. Now, coming back to what we are talking about, infrastructure and developing stroke ready centers. Now we have to think differently for tier 2 cities, tier 3 cities, and the metros. In tier 2 and 3 cities, we are aiming high, but immediately what we can do, how impactful we can reach ourselves for equitable stroke care. It's very, very important. We are talking of a select population where we offer TPA or IVT and mechanical thrombectomy. But what happens to the tier 3 and tier 2 cities? We are thinking, we are dreaming big, but in reality, is it possible in near future, next few years? So we have to think of what best we can do is AI-based softwares are there. As Dr. Mahajan said, every taluka place, every district, forget district, even taluka places, and nowadays villages are having CT scan, which can be 6 lives, 16 lives, correct me if I'm wrong. And there we can do at least confirm that patient is not having an hemorrhagic stroke, start treatment, have telemedicine setups, and we can call this as model 1, that this stroke center, which is a stroke ready center, ready to gear up for at least starting with the thrombolysis in time whenever they present. And there, mind you, the people who are having large vessel occlusion or a major stroke, they reach the hospital within time. I have realized that these people are well aware, they reach in time, though they know that the person is having stroke, they reach in time. But because of the manpower availability, non-availability, we lack in starting the treatment on time. So this is a different strata which we are not aware. So we all our experts have to think about those situations also and add how we can, a little difference to them is going to make a huge impact on the outcomes. I'm sure I'm promised to that I have noticed, I'm experienced, and that would be a game changer, trust me. So how do we develop these role models? The policymakers should come forward. A CT scan, whichever center is there, we incorporate AI-based softwares, giving us the window period or perfusion-based reports. We integrate them with the tier 2, tier 1 cities or the hub and spoke models, and we can start treatment, and we should build our drive towards making such centers, and we should standardize the protocols. Like, see, if you think of the chains which are there in a food system, or you can say Blinkit. Why they are successful? They are making a protocol standardized that every Starbucks will have the same taste, same module, same infrastructure in any part of the world. So we should standardize that. We can develop a model, take opinions from all the office bearers, and see to it that we develop model 1 for tier 1 city, model 2 for tier 2 city or tier 3 cities, and different models for different cities, and cater to all the population. We should reach every village of our country, and that would be an impactful stroke care, and that would be, I think so, offering the rights of healthcare to each individual.
Thank you. Thank you, Dr. Dhanke, for that very insightful points with regard to stroke units and how that is going to make an impact and what are your personal experience with regard to improve upon that. Since we are behind time and we need to finish fast, so I just now want to Dr. Goel to ask regarding, because Goel has been involved in a lot with regard to training these young interventionists and also having programs also, even conference and meetings with online workshops with the international faculty. What is the way forward for India with regard to having more and more interventionists coming into the system? And in what way we can give some funds to the policymakers to with regard to what would be in a short that point of view to have some kind of a training wherein there are a lot of stroke fellowship programs happening in many of our all India institutes, all these institutes, but we are not able to give training for them with regard to intervention. So what are the way forward with regard to these activities?
And I think it's a very important question because we can develop all the infrastructure, because, but if we don't have the personnel, as you mentioned, like so we do need the mentors, and I think training, we all are running fellowships and training programs at our own level. But the challenge is how do we train more? And I think we have tried simulator-based training programs, but that doesn't equate what we can do for humans and the different challenges which comes across. And very recently, I don't know if you are aware, there are certain groups in Europe who are doing cadaver-based training programs for acute stroke. So they are making these cadavers sort of lift back again, so the heart is pumping, the blood is flowing. The anatomy of each is different, the polatic circulations are different. And that's probably the way forward in future. The second option is, of course, the AI-based models again, that we create those models and then we can ask the trainers to be training on them for 30, 40 cases before they can go and do the individual cases. I think there are enough skilled people, both from radiology side or neurology or neurosurgery or from physician side. But we just need to impart proper training. And I think courses, to summarize, will be the training courses in government and private hospitals, simulator and AI-based algorithms, and something innovative like cadaveric-based programs, which can actually be the game changer for doing the acute stroke programs. And I think one important discussion, I think which Dr. Mahajan said, to incorporate in the school textbooks, but I think more than that, if we can, in all the medical schools these days, there is simulation workshops where people learn to train on cardiac CPRs and things like that. But can we incorporate a little bit about stroke there, that, in those simulation rooms, the basis of that, and that can lead to a bigger changes, what I think.
Dr. Gaurav, thank you. I think very important points with regard to, I think the school education becomes a very important thing. I think that is something which is lacking. We should make it a point to have in the school education something about stroke and what are the latest treatments available, so that they will at least be able to go and tell the family with regard to these other treatments available and what they can do. So because we don't have much of time, I would just like to ask Dr. Ajay Kumar, who is a professor of interventional neurology at PGI Chandigarh. So we already talked in detail about the challenges with regard to endovascular treatment and we have heard from Dr. Gaikwad regarding what are the challenges. But I would still like to ask you regarding what are the challenges you face with regard to as a interventionalist, especially with focusing on endovascular thrombectomy in a public sector. And what is the perspective of the patients and the family with regard to when we are offering the treatment to them, because that's also very important, because people think that, oh, such an expensive treatment, why should I go for that? So what is a way in which we can further make an impact on them so that more and more patients receive the treatment?
Yeah, thank you. Thank you, ma'am. So as we are talking about the stroke, the most important thing, the stroke is very much time bound. So the diagnosis, the time to reach the right place. Right place, I mean, where the patient can have the ability to diagnose, whether it is clinically or imaging wise, and then the treatment, whether it is the medical treatment like IV or intraarterial TPA or mechanical thrombectomy. So that is the comprehensive stroke care unit. So in government sector, when patient comes to us, especially I'm talking about the PGI, the problem starts especially when the patient is completely diagnosed and large vessel occlusion is there, and the diagnosis at PGI, with great thanks to Professor Khurana, we have great team, and the diagnosis and the all the evaluations are done very fast. But the problem starts when we are talking about the treatment and the financial implications. The patients can be of four type, like if it is well paying, no problem, go ahead, treat the patient, and these patients are very much rewarding. If the patient is within 4 to 5 hours or 6 hours, and the patient is coming without half of the body is not working, and you do the thrombectomy, and you see the magic just on the table. They start moving their limbs. So treatment is very rewarding. But the problem starts when the patients are like just paying without Ayushman beneficiary, or the patient is poor with the Ayushman beneficiary. And the worst is when the patient is poor and he is not beneficiary also. So this is the main chunk, which is at least about 1/4 of the patient which reaches to the government institutes. Because whenever patients are going to the government institutes, uh, it is implied that patient is going to be poor. So this is very much important. So where is the gap? The gap is there, cost to the patient. The cost to the patient, the difference in the cost to the patient and whatever is being approved from the Ayushman, there is difference of at least 50,000 to 1 lakh. And those are the patients, like there is the problem. And I'm very much happy. I'm happy that we are sitting here and all the stakeholders, which are, one is the patient, which is not there, physicians, we are here, the like industry guys, they are there, and administration. So if we can fill this gap, our industry guys are there, they can reduce the price, this special condition, and administration is there, they can increase the package. So we are somewhere in between, and the doability of these patients are achieved. So this is very much important. This is the gap. And what do I suggest, which appears to be impractical right now, but with the guidance of like Government of India, which is already after Ayushman Bharat, the inclusion of the patient of a stroke is enormously increased, more than 60 to 70% pre-Ayushman and now. So the inclusion of the patient for thrombectomy is significantly increased, but still we are losing some because of this gap. So what I propose, if we can have like, as we are having cashless insurance, my car bank somewhere, I have to get out, go to my home, insurance person will come and they'll take care. That is cashless. So that is very much standard this thing. But if we can achieve somewhere near that the patients can be cashless for this special condition. Another important thing, the approval. Approval from the Ayushman counter or PMJ counter from different hospitals. So this approval takes some time. And we know as and when we are losing time, 5 minutes, 10 minutes, आधा घंटा, the lab is there, and we are having 3 labs. We are having more than 5 senior operators who are at the senior level, and we are having more than 10 DM neuroradiology students who are 24/7 available. But we are waiting that we can take the patient. So these are the gaps if these can be filled.
Thank you, Dr. Ajay Kumar. I think those are very important with regard to still cost is always an issue.
Yes.
And I think once the packages are being revised, I'm sure it's going to have a real impact with regard to management. And as rightly pointed out by Dr. Ajay, the industry needs to make a really big impact with this. And I think here the most important thing which comes out is low-cost devices which are being developed in India now. And there are 2-3 companies which are making the devices. And even in Sri Chitra from our biomedical technology wing, we are developing the devices. So I think that is also something which we may have to look into because of the burden of the stroke patients. I think there is a need to have low-cost devices too, just like we have for the cardiac with regard to stents, where we need to have more of those devices to have an impact. Next question I would like to ask Dr. Tariq. We have been repeatedly talking about having the treatment available with better awareness. Is India still prepared for that? So if you have, as Dr. Jairaj has been working for the last few years with regard to certification of the centers, so that in the next few years, if you have more and more centers certified, so at least patients will know once they have a stroke, let me go to that certified center. Even if you have, I think Jairaj, 100 should not be the target for next year. It should be at least some 300 or 400 centers being targeted for certification, so that people will know in each place where to go for so that they will be motivated to have the certification, and that will improve the quality of care. So where do you think is, like, if you have more and more centers certified and you have more of endovascular centers, then you still have a gap of neurointervention is not available. So what is the short-term gap of, what are your 1 or 2 points of suggestions wherein the policymakers can get involved? And I'm sure Medtronic and team can bring in, because in the Mission Thrombectomy Initiative, I can still remember Dr. Dilip Yagawal talking about proctorship programs where many of these centers may be doing about 5 or 6 in a year. How do we train them further to have a confidence in doing these procedures? So what are the few points which we can bring it out in the action plan with regard to how to have more and more interventionalists to do this procedure? They don't have to do embolization or coiling. They need to do just some stroke thrombectomy and the carotid stenting probably.
Thank you, Dr. Sharja. So it's a bit controversial statement, but you have asked. As we have come through all through the talks, we have realized this thrombectomy is a powerful treatment, groundbreaking, and is a transforming treatment. We need operators to have down there on the ground. And there is, as Dr. Jairaj has mentioned, there is a dearth of professional there. We need to upscale on that dearth of professional. So on training aspect, we have 2 sort of programs, 2 spectrum. The spectrum lies here where we have got a formalized and structured program, and the spectrum is non-formalized, non-structured program. And these are churning out operators. Again, echoing the point Dr. Sailesh Gaikwad sir has made, we need operators who can produce results, who don't produce complications. Okay, if there is a learning curve, they can ride through that learning curve. That's well enough and good, but the learning curve has to be rode through, and we need results because this treatment is a powerful treatment. We need ample good result to support that thing. And the Pran have suggested we can do it. We can do it. Coming to that formalized treatment structured program, we need to sit, because there's a lot of controversy which goes on among the specialities, interdisciplinary things. Now we need to form a melting pot. It's not a salad, it's a melting pot. We have to understand. We have that culture, we have that knowledge, know-how, but when we talk about a neurointervention is a speciality, it's an entirely different speciality, where all those structures thing helps, but you need to come into a melting pot to develop a right structure program. Probably we need to think, form a program where we can create more operators. The other thing, a lot of has been said about the hub and spoke thing. Yes, I have seen, because I'm traveling length and breadth across the country, the hub and spoke is happening. In fact, we are making it happen at our center. So hub and spoke is not a failure. It's not a thing which is not happening. It's happening. We need to strengthen hubs. We need to cut down the size of spokes. That means you need to create more hubs, that you need more operators on ground so that you create hubs with a good training program. And what of the very short-term thing probably which can yield result is traveling across, we have seen the labs, the unutilized labs in the government health sectors, medical colleges, which is there. Probably this is one of the area where you have got the infrastructure, you have got the patients which are pouring in. Just you need to train those people so that, as Dr. Gaikwad sir has suggested, we need to train these people where you can utilize the centers. They become a hub for that area, and they try to gain on the spokes. They form the spokes. So has to be decentralization which has to happen, and we need to think beyond that regarding that structured program. Yes, we all can sit and develop a structured program. We can think in now coming to a point which was made. We need people who can do thrombectomies. In fact, we are admitting neurologists, neurosurgeons, radiologists, all are welcomed in our training programs. A neurologist, I'm sorry to say, a neurologist, when he comes to us with a training program, he says, okay, I have seen patient getting good results. I need to do those therapies. Probably I will be sitting in my OPD. Patient comes in, walks in, and then I will do a thrombectomy 10 minutes and come out, and again will be writing my prescriptions. That doesn't happen. That mindset has to go out, because a neurointervention program is a full-time program where you need to be dedicated, because those things doesn't happen in 10 minutes because you need a training background. You need a background to make those things happen in 10 minutes. So there has to be complete structured program, and the neurointervention has to be taken as an entirely different specialty.
Thank you. Thank you for that very important points. But still, I think in that perspective, having a combined discussion and having some kind of a structured program is relevant to a country like India, where we don't have enough interventionists and we have got a lot of strokes to be treated. And once the policymakers brings in the higher Ayushman Bharat packages, India needs to be ready for taking care of these patients too. I think it's a kind of a ball game where we may have to look at what is the best way to get the most effective treatment. And I would say now we have Dr. Jairaj in the World Stroke Organization as the president, and the WHO is in fact planning to have some kind of combined kind of programs where we can bring in international faculty to also be part of this. So I think those kind of fellowships, I think these are the ways in which with the policymakers to have some kind of a link wherein we have more of interventionalists also coming in, because that is one treatment which really makes a difference. So we really need to work towards improving it. I'm sorry that even though we are late, we had a very good discussion. I would like to thank all the panelists and all the delegates for being here. And I think one of the few points which I just want to mention is that we really had a discussion with regard to how to improve upon the delay in the arrival. We had very important points which has been highlighted by each of the panelists. Second is how to have more and more stroke centers, stroke ready, and also with regard to some kind of a Google map where the patients and the relatives will know where exactly the centers to go. And here the certification becomes very important. Improving or the Ayushman Bharat packages. I did not go into the area of rehabilitation and secondary prevention because that is being taken up in the next panel discussion. So we have totally confined ourselves to acute revascularization therapy. Thanks to all for this insightful discussion. Thank you.
Ma'am, one small comment whether participants we can make. Only one.
Yes, yeah.
Ma'am, it is a very wonderful opportunity where administrator, the specialist, the industry, all are there. I am Dr. Girish from Nimans, Bangalore. Implementing hub and spoke, some of the things I experienced, I thought that I will bring to this because this can make a difference from this summit. Ma'am, basically health is a state subject. Majority of hospitals in government set up as state government. And the policy and other things should be driven from the central government with suggestion to the state government, like what all the things to be done. Like accident is there, some amount of money can be done. Like that, some incentive for the state government hospital where hub and spokes are there, where intervention can be done, ma'am. And time bound thing, like this should be developed in a state, like 3-4 spokes and hub should be there. Some suggestion should come from the center so that state can be there, because majority of the people who are working on stroke hub and spoke and intervention, they are in either in a private or in the central government, and coordination becomes a difficult. So if one document comes, we will be there to take it forward. That's what my.
I think Dr. Girish, that is a very important point. I was actually, when we were coming together yesterday, I was talking to Dr. Bibin, who is the state nodal officer for Kerala. What is the way in which the center, you make some suggestions, how best to get it practiced in your own state? I think it's a thing which needs to be discussed. And from the center, you need to give really some important points which needs to be carried out definitely, and mandatory ones and less important ones. Thank you.
Thank you. Before the group photograph, I'd like to request Dr. Harsh Mahajan to felicitate Dr. L. Swasticharan. Just a quick felicitation, please. Before the group photo, just 1 second before the group photo. Dr. Mahajan, please. And now the group photo. Ladies and gentlemen, a quick announcement. There will be no break. We will immediately go into the second panel discussion. So I would like to request you all to please stay back. Ladies and gentlemen, we will now begin the second panel discussion. I kindly request you all to please stay seated for the upcoming discussion. I was going to invite you. Is that okay? All right. Ladies and gentlemen, we will now begin the panel discussion 2. This discussion is about transforming stroke care delivery, innovations, and collaborative models and quality. I kindly request everyone to please stay seated. And I also would like to take this time to invite our chair, moderator, along with the speakers to the dais. I'm going to, no, it's sort of like not settled in. Ladies and gentlemen, I'd like to repeat, please stay seated. We need to begin this panel discussion. I'd like to invite Dr. Kameshwar Prasad, Emeritus Professor Neurology, AIMS New Delhi, and Head of Department of Neurology, Fortis. I'd like to also invite Dr. Vipul Gupta, Group Director and HOD, Neuro Interventional Paras Hospital in Gurugram. And along with our chair and the moderators, I would like to invite our speakers, Dr. Atul Kochar, CEO, NABH, Dr. Kalpesh Shah, Senior Consultant Neurosurgeon and Neurointerventionist, Zydus Hospital in Ahmedabad, Dr. Dheeraj Khurana, In Charge Stroke Program and Professor Neurology, PGI MER from Chandigarh, Mr. Gaurav Vyas, Head IGT Systems, Philips India, and Dr. Tamagna Ghosh, Director of Products and Lead Radiologist and Neurocritical Care Suite, Cure AI. We are delighted to have our chair, moderator, and our speakers on the dais. And at this time, I'd like to hand over to our moderator, Dr. Vipul Gupta. Sir, over to you.
Thanks for the introduction. So we had a very interesting and dynamic session. And now we move on to this panel discussion number 2. And this will be about the stroke care delivery. What are the innovations and what are the collaborative models, and we maintain quality. And I think it's particularly important in our country. We are talking about huge population and some resource crunch. And we look at some success stories and learn the models and how we execute them in Indian context, particularly like, although it has been discussed a bit, we'll discuss more in detail about hub and spoke, how we can use telemedicine, which is very efficient, telethrombolysis. There have been publication from this country. AI driven has been discussed, and thankfully we have got Indian companies and who have got AI solution. It's already being used in our country, but how can we expand that reach? And as I said, we learn from real life experiences about success stories and executions and how we can have some takeaway point. So my request overall will be to all my fellow speakers and panelists will be that we focus on take home points. You know, there are a lot of people here, so we have got a good forum here. Take home points in their answers and their discussions, which we can carry forward and which are executable at one level. All right. So first of all, it's a great honor to invite Professor Kameshwar Prasad for a special address. And I was a student under him in All India Institute of Medical Sciences. And I would really like him to also cover in this special address about national stroke guidelines and how we can collaborate along with the WHO, ISA, and World Stroke Organization for this execution of these guidelines. Sir. Thank you.
This one. Okay. Thank you very much. First of all, I thank the organizers for inviting me. But really, the person who forced me to come here is Dr. Vishnu Panigrahi, who is head of medical operations in Fortis. And I told him, you know, this is a day I won't like to go out of my home because this is my birthday. He says, no, this. Now, the way he attracted me, this has been kept only because of that. So I said, okay, now that is, if that is the case, I will attend. I'll finish very quickly because 10 minutes is allotted to me. But I'm going to slightly change. Now you heard that emphasis will be on rehabilitation, secondary prevention, and so on. I'm not going to spend time on the burden. You know, at least we have 12.5 lakhs. Dr. Pandian says 18 lakh cases of stroke every day, 85% occurring in low and middle income countries. And look at the cost. Globally, the cost is about in Indian rupee, 89,100 crore. It was in 2017. In 2050, it is 2,31,000 crore going to be. Even if it is 1%, in India, only 1%, I'm taking into account purchase power parity of dollar and all that, it will be 75,000 crore for 2017, and 2050, it will be 2 lakh crore. So India has got to think that it is something which investment is necessary to prevent this cost. And the strategy to reduce the burden of stroke revolves around management of acute stroke, which has been discussed, secondary prevention, and also primary prevention. That is, not allow stroke to happen. And when we think about this, we have to think slightly differently. And different thinking means, suppose we have 1 million population, there will be 1,500 stroke cases in a year. Out of that, 1,200 will be ischemic stroke cases. Among the 1,200 ischemic stroke cases, let's say 25%, which means 300 will have large vessel occlusion. So what Dr. Pandian is saying, we want 5% of these people to get at least thrombectomy. 5% of 300, you can imagine, will be about 15 cases. So by doing a thrombectomy in 15 cases, at the most, you will increase the chances or reduce the death or disability in about 3 cases. So 5% is not a very important goal from national perspective. Similarly, you have to think, the reason is we are talking of 5%. The moment it becomes all of it, there will be substantial gain. But I know it is not easy to achieve. But this is the way we have to think about each intervention. And WHO, who, as Dr. Vipul said, they have a brain health unit. Unfortunately, I'm a member of brain health unit, which directly advises the Director General of WHO. I don't know whether WHO will survive with Trump's withdrawal from funding or not, but whatever it is, we generally help WHO to develop guidelines which countries will adopt. And we had one such guideline where we emphasized, first thing, stroke unit. We emphasized very heavily on stroke unit. We had lengthy discussion in Ministry of Health. I was fortunate to be convener of this guideline. And hours we calculated how much is the cost of stroke unit. And ultimately, they said, no, stroke units, coronary care unit, both not possible. So what we'll do is we'll make one critical NCD unit. It will not work. We have to have stroke unit. And in fact, I would suggest, rather than calling stroke centers, we call stroke units. Basic stroke units, comprehensive stroke units. Let us get it in every medical college at least. But in terms of effect of the intervention, effectiveness-wise, aspirin is good, but it has only 1% difference in number of deaths or disability. Thrombectomy has 20%, so huge difference in the effectiveness. But when it comes to coverage, aspirin, every ischemic stroke will practically get it. But when it comes to thrombectomy, we are aiming at 5%. We may aim even 10%. Even then, coverage will be very small. So that way, if you calculate for every million population, you see thrombolysis will save 6 death or disability, but stroke unit will save people from death or disability, which will be 65. So you can imagine stroke unit, because of larger coverage, 90%, even 100% patients getting it, it will have much more impact at national level than thrombolysis. Or in this one, thrombectomy is not there, but you can raise it to double the thrombolysis, 12. Still, stroke unit will save a lot of death and disability. So what we thought in terms of innovation, Australians did this. In stroke units, they made sure that fever, blood sugar, and swallowing is controlled very well in every patient who is admitted. And they showed a difference of about 18%. So we also developed a stroke care pathway, which we first tested in AIMS. This was one of my residents who did this. And then now we are doing it country-wise. So ICMR has funded about 20 medical colleges. Simple things: controlling fever, blood sugar, high blood pressure, and swallowing. So you will be surprised to know 15% patients have poor control of fever. 25% people in the stroke patients have very poor control of blood sugar. Nearly 50% patients with ischemic stroke have very poor control of blood pressure. Nearly 100% patients of brain hemorrhage means intracerebral hemorrhage, have poor control of blood pressure. These are also things which we need to do. I'm not going into the risk factors, which you already know: diet, alcohol, tobacco, exercise, blood pressure, blood sugar, cholesterol. Now, most important thing is, when we talk of prevention, healthy lifestyle reduces 80% of risk of first stroke. So it is as much important as it is in so many other conditions we talk about healthy lifestyle. And the most important is high blood pressure. High blood pressure has a strong, continuous, graded, consistent, independent, predictive, and etiologically significant relationship with stroke. So if you want to think about secondary prevention, and again, you think about 1 million people, and if you do different things like use blood thinners, control blood pressure, control blood sugar, where do you get maximum effectiveness? It is in controlling blood pressure. That is to the tune of 49 people who will be saved from having a stroke. And recent advance, you can say, is double antiplatelet therapy, which was not there earlier. Not so recent, but it is something which we have now incorporated in the guidelines. In terms of primary prevention, means people should not get a stroke. What do we do? If you control blood pressures, cholesterol, anticoagulation in patients with atrial fibrillation, smoking, where do you get maximum effectiveness? Again, blood pressure and smoking. So if you really want to work out prevention of stroke, these are the areas where government has to focus from national perspective. It's very important to have acute management, which has been adequately emphasized, but I think this is a saying which we should remember: an ounce of prevention is worth a pound of cure. And to summarize, stroke units with control of fever, sugar, swallowing, and hypertension is the most effective treatment, perhaps. Thrombolysis is very effective. Thrombectomy is more effective. But remember, prevention is better than cure. We should emphasize as much primary and secondary intervention based on control of high blood pressure and smoking as we do about thrombolysis and thrombectomy. Thank you very
much. Thanks a lot, sir. I think not only because I'm moderating this session is very important, because we're talking about models of stroke care delivery in our country. And stroke is a mass problem. So although I am a neurointerventionist and I've always promoted thrombectomy even before 15 years back after Arving, but thrombectomy, as sir mentioned, is not the solution for stroke management in our country. Because how many patients will really get it? Prevention and having stroke units, as sir mentioned, and having stroke units controlling some risk factors such as sugar control, blood pressure control, fever, and swelling, which lead to much more improvement, much more in terms of efficiency. in improving outcomes overall on a base of the society. So although, yes, I'm a thrombectomy guy and we should have high-end thrombectomy units, but sir brought out very, very important points of stroke units, lifestyle, and blood pressure management, which has to be incorporated as part of stroke care delivery networks or programs. Thank you, sir. And now I go to Dr. Atul Kochar. So from, NABH started the accreditation stroke center accreditation program. Now, but it is very important that everybody understands that how does it help in increasing the number of stroke centers and improving the quality of care? So would you like to elaborate on this?
Yeah, thank you, Dr. Vipul. So essentially, thank you for having us. And NABH is one of the autonomous boards under the Quality Council of India. And we've been drafting and assessing against our own standards for past 19 years. We are into the 20th year. And anywhere there's a need which is felt for drafting standards, then NABH steps in. And we are very proud to tell that under the three broad headings of accreditation, certification, and empanelment, today we partner with about 23,000 hospitals in India. And we have presence in 8 countries currently with 18 hospitals in Middle East, Iran, Oman, Dubai, and all the SAARC countries except probably Pakistan. So with that kind of a legacy, I think it was a knowledge eye-opener for us when Dr. Pandian, on behalf of WSO, reached out to us, and we met Dr. Sheila Martins, and we were there in WSO conference at Sao Paulo. And over the next 2 years, these standards were crafted with essentially a third-party oversight. See, it's, the international world is looking at us, and stroke being what, as sir has just mentioned, with a huge focus on prevention, promotion, the right kind of care, it becomes very imperative that you should have standards which are not only cutting edge, but they also promote all aspects of care, including the prevention and promotive care. So with that, when the clinical experts themselves drafted these standards, Padma Madam was instrumental, Dr. Pandian was there, and a whole lot of our experts, Dr. Vishnu was there. They all contribute to drafting of these standards. And standards are nothing but a set of international best practices which are continually improved year on year. And they are a benchmark we set ourselves for. There are key performance indicators, there's a third-party oversight, and ultimately, over a time, you notice that it leads to a level of improvement which was not there earlier. So that's the basic thing. And coming to your question now, Dr. Vipul, over time, we noticed, and I can speak unhesitatingly on behalf of all the smaller hospitals. So there are 4 tenets of accreditation. First, you should have a published standard, which are there. And then there are the basic tenet. There's a third-party assessment, which is performed by peers from the industry. So we are very proud to have about 2,000 assessors. And of that, now 20 of them are about the best neurologists, brains who are willing to spare their time for this cause. The third is a continual improvement, which is there. And fourth is that an independent decision is taken by a committee. So over time, the bigger hospital, they respond, and there's a sustained capacity building. There's a focus on hub and spoke model, which is there. So the bigger hospital lead to interest also, and a capacity building, authentic training also in a hub and spoke model also. So ultimately, the entire ecosystem flourishes from the knowledge sharing and collaboration.
Yeah, that is absolutely wonderful. On a personal note, we Indians are quite brilliant, right? We are very skilled, very knowledgeable. Then why do we perform much better in West than in India? And I personally feel because we don't have systems here, systems to perform here. And I'm happy that, accreditation system helps us to provide systems in which all of us can perform better. And hopefully not only that, future it can lead to more data gathering and having more Indian publication and Indian way of dealing with these patients. So I'm very, very proud. And as you mentioned, presence in other countries, maybe this will be a future manifestation Indian soft power, as the Prime Minister said, of transmitting these.
So
to the
rating and
adjacent
ranking
countries.
of hospitals is our next big project. Dr. Vishnu again is an active part of that, is part of the steering committee led by Dr. Narottam Puri, and active part of Dr. Harsh Mahajan is also part, ministry is also part. And data outcome monitoring is ultimately the key component of that. And on the subject of stroke, there are 560 centers already, and which we hope to aspire. There are already 15 applications which are there with us, and these 15 is just the initial thing. And this is all happening in direct collaboration with WS. So my short answer being that it's very easy to draft standard. You just pull together data, create references, get the references, and create standard. It's a third party oversight by the peers with independent decision taken by a third party committee, which is of absolute importance. And here NABH has an expertise, not only in one program, but 29 programs. So we operate 29 programs, each program being a subject specialist. We run program for dialysis, we run program for allopathy clinics, now with RSSDI for diabetic clinics. So each has certain unique nuances. So ultimately, it's the specialty themselves which handles it. IRIA endorses our medical imaging standard for radiology. So similarly, when experts from each department, they handle that. And Dr. Pandya, of course, has been instrumental in spearheading the stroke clinic and stroke center of excellence standard. And there's another small angle of insurance companies. So insurance companies need certain standardization.
That's very important.
The payer perspective is extremely important with the PMJ coming in, with the all those aspects, how the industry responds to those requirements. They need certain evidences that authentic care has been provided. So here a role of a national body comes in very handy. And here the importance of standard is there.
Not only that, once this catches on, I'm in private sector.
Yeah.
If there are 5 private hospitals and 1 or 2 get it, other 3 or 4 feel compelled, and that process will improve the delivery. So that's very important. But let us look at it from the other angle, the accreditation. How does it changes in terms of public trust in stroke care innovation and motivating public to get better treatment? How does this accreditation play a role in that?
Very important, extremely important. I mean, I think we are amidst times where the patient's trust in the medical system is at a absolutely low level. I mean, it's always been low. We are on the other side, but accreditation as a mark of excellence reassures the patient that, see, this is carrying a logo. At least my rights are going to be protected. Some sort of due diligence could have been done. And today we again are very proud that 18 of the 22 AIMS are partnering with NABH, with AIMS Delhi, AIMS Nagpur taking the lead. All the bigger hospitals are with us, RML, Safdarjung, they are on the path of accreditation. They already have achieved certification. So with all those things, and what to say of leading chains listed chains like Fortis, Medanta, Narayana, we have 95% share of the full accreditation in the regulated space, if I can say that, because only very few listed authenticated sources are there. So this is a huge aspect of trust of the patient into the system. And because our standards are continuously revised, I mean, we have a 4-year cycle, we have a quarterly way of capturing key performance indicator, we have a mid-cycle surveillance. And now with the star rating and ranking coming in, the entire system will be driven on data. We have digital health standards, we have standards for HIS and EMR systems also, which drive all big hospitals. So I think the next decade is, or no, decade is too far, but next 2 years are going to be very critical, very important, and very, very optimistic about the way healthcare will change in the country.
You're absolutely right. In fact, I'm in private practice, and people, all of us say about money and patient don't have money. But my experience also is, if patient and their family have faith that the right thing is being done with right intention, they don't mind the payment. The issue comes in trust, the gap, whether all this expense means rightly it is being done. And definitely having accreditation, particularly by outside authorities, and which becomes well known, it improves the faith, and people are willing to spend. So it's a paradox. It's not only that people don't have money, It is that lack of faith that the right thing is being done, it actually stops them and makes them question and causes delays and lack of treatment. So
Objectivity, transparency, and with time with
Yes,
that will come,
that
just
is-
like in the US, we have best doctors in California, best doctors in
Yeah.
Orlando, Florida. You will,
let us
day
see.
is not far when best doctors of Delhi, Mumbai will be
That-
not
that-
decided by magazines and polls and pseudo awards, but by authentic data, how much infection control, what
That
is
is-
the reversal rate,
Yeah.
as sir mentioned, of swallowing, what the key
Absolutely.
outcomes? I mean, that will be the day when.
Yeah, so we talk about stroke care deliveries, as Sir Dr. Kamshu Prasad has brought out, having stroke units and simple management issues which can bring big difference. And second part, in this system itself, we can have accreditation comes in, which improves the delivery as well as public faith going into it. And now we come to a point which has been discussed before, but it has been touch and go about hub and spoke. So I would like to ask Dr. Professor Dheeraj Khurana, and he has been a pioneer of stroke program in Punjab and one of the leading figures as a stroke neurologist. So what about your view about hub and spoke and execution, particularly you have any experience in Indian context about it? Yeah.
Yeah, sure. Thank you, Vipul, for the question. So I think this entire story of hub and spoke, just to put it in perspective, we've evolved over so many years. Just as Mr. Kochar just put it, we are at the pinnacle of not at the pinnacle, we're close to reaching the pinnacle of health delivery and health service. So that's what happened in stroke services. Over the years, first of all, we were dealing with developing stroke centers, developing training people to start thrombolysis, then went on to thrombectomy. And finally, when we realized that, okay, we have the necessary expertise, we don't have enough physicians or we don't have enough neurologists to take care. This is where the birth of hub and spoke happened in India, and that was already being carried out in the West. So the hub and spokes right now, like we've been listening to it since morning, there are hub and spoke models, but I think this is one focus that we all need to really put into actual real hub and spokes. So we've been having hub and spokes by, for example, the experience, like you said, we've had in Punjab, somewhat in Haryana. I've been mentoring Haryana State too for the initiation of the stroke program, and of course at Chandigarh. So for us, a hub and spoke means getting all the district hospitals into our setup and training them, and then training them into identifying stroke and then referring them to the hub. So primarily, a hub and spoke is nothing, in simple words, that we call it as a service provider. It's nothing but a provision of a service. So a service which in terms is provision of a stroke treatment, which is not available in those hospitals. Now, the entire issue with this is this needs to be standardized, just like we heard about the NABH. And this standardization has to be sustainable. We start a service, we would carry on with the service, but in most of the district hospitals, the biggest fallback is the physicians or the people who are training, whom we have trained. There's a very fast turnover. So whenever there's a new team which comes into the district hospitals, the entire system collapses. And this is not only this is my experience in Chandigarh. So that kind of is a very, I would say, it's like a burnout. And for that burnout this is where technology comes in. And technology is, I think, one of the key drivers of a hub and spoke, which we are looking at certain technologies being used in different states. We created a similar thing in Chandigarh. We created an application where, the different hub and spokes could be connected. And we actually had a good success in hospitals. Like we have, for example, the main civil hospital of Chandigarh, which was not thrombolizing forever. And within 2 years, we could take their rates up to quite a good. And the interesting part was we had, of course, done it as a study to compare their outcomes versus the patients who came directly to PGI, and they were faster. The key, the timings, the door to needle times were faster. And the reason is because the hubs are more crowded. And this is what I think what I would like to really make everybody be a little bit more awakened to the fact that a hub is always crowded. So if you're going to have hub and spokes, if we are planning to do that, and we already are doing it, we need to see that we don't overcrowd the hubs. Because that patient who has been referred for the right motive will not get that treatment because that hub is already overburdened. So this is where our planning of the hub and spoke needs to be redone. And this is exactly where a good planned hub and spoke will make all the difference.
I think this was very interesting to hear. Now, hub and spoke we need. Why? I mean, we need it because this needs fast treatment, right? You can't have somebody seeing and then calling up and then transferring the patient. That window is gone. So we definitely need hub and spoke, and particularly lack of resource we know. But very interesting to hear from Dr. Dheeraj how in Indian context, whether when district hospital people change, it collapses, or whether in a government setup particularly, and in private, I guess it can happen so that, the central hospital can get overcrowded. These are unique Indian situations. And of course, this is coming from government perspective, public sector perspective. Now we come to private. I mean, we'll have further discussion. There may be some different challenges hub and spoke. And again, you have to look at Indian issues and Indian solutions in developing hub and spoke.
So yeah, so one of the biggest challenges, like you did mention about a private setup, is it's like the bridge between a private and a government hospital. So if we have to have a combined system where you have hub and spokes of the government, spokes of the government, and the hub of a private, now this is where is the biggest challenge. Who pays? So this, I think, is the biggest challenge which is facing our country is not a unified health system where people from the spokes who, if the hub is nearer is a private hospital, who takes the coverage? Or patient takes a longer time to reach the hub, which is a government hospital. So these are the biggest challenges we still face. And there is no one solution which has still been settled for this, which I think needs to be worked out and create a plan, create a solution and a sustainability solution, which I think is possible. I've had some discussion, some thoughts on this. And in fact, we've tried to create hub and spoke, and I've applied for funding to ICMR. It's still not funded. What Dr. Swasticharan was saying, you have a hub and spoke. You have a patient who's in an ambulance who needs to go to the right place. The ambulance doesn't know. So maps are not the main thing, but it's a kind of a grid system where you have a central communication, and that communicator can direct you to the right hospital, which works in the West. It's missing in our country.
Yeah, absolutely. So hub and spoke is the key because in stroke, we know outcome is time is the key. So developing efficient hub and spoke is the only solution. It's not one of it's the only way world over is being delivered, and we have to develop our own solutions to it. But as I mentioned, we again talked about thrombectomy. I'm a thrombectomy guy, but as Professor Prasad mentioned, all prevention and simple management strategies make a difference. Another big difference, I always say, I do the thrombectomy, but the physiotherapists get them up. Bottom line is how many people will get acute treatment. So we need to have very good rehabilitation centers as well. So if Dr. Dheeraj would like to elaborate on some advances in rehabilitation technologies and your perspective on this.
Sure. So I won't really talk on advancements because that won't really serve our purpose. Advancements are many, but that's all technology. So we won't really reach out to the public. So what I would like to really focus on is the lack of access to rehabilitation. Everybody needs rehabilitation for all neurological disorders, more so for stroke. 90% of your patients, even despite all thrombolysis and discharge, we know would need some bit of rehabilitation. And it's a fact that close to 30 to 40% patients are discharged with some needs to go into a nursing home or further care. And only 10 to 15% will really suffice with a home care rehabilitation plan. And out of those, there's going to be a good deal of 15 to 20% who will have a recurrent stroke in 1 year. So this is where rehab is a big unmet need of our country. It is the least, I would say, there's a huge lack of accessibility. We've done multiple studies because that's one of the areas where I'm interested in looking at rehabilitation currently. So we've developed some protocols, we've developed some trials which are doing. So we are leading one of the major post-stroke rehabilitation trial in the country, which is under the Instruct network, where we've created the application. So that would provide us evidence. So that's one way of reaching out to people to, it's a self-based kind of a service where people can look for post-stroke rehabilitation. But one key way of making people reach rehabilitation, which is still a model only available in Western countries, and that to few European countries, it's not even fully developed in developed countries, is community-based rehabilitation, CBR. I've talked of it earlier in other earlier forums too. Now that is completely not being talked of or not even being mentioned in any of our discussions. A CBR has to be pushed where communities, there are volunteers who can give the rehabilitation on a community, just like a primary health center, you have a community-based rehabilitation center. So till date, it's only one country which has shown a success, which is Germany, and not many other countries have shown it, but it's one of the most successful models where people are rehabilitated and they can join back society, because in a collective manner, you understand what rehab is not just exercise. It's also about reintegration back with the society.
I think this is very, very important. You know, it doesn't sound glamorous, rehab. All other things sound glamorous, big words, but this is the key for 99% of patients. And sadly, I'm in private sector, hospitals don't focus, and hospitals can't take care of these patients. Hospital will get overcrowded anyway and becomes too costly. So having other models for rehab centers or community-based centers, as you mentioned, is very, very important part of the stroke delivery. So now let me go again, how we use technology. So talking about all this theory, and let me go to Dr. Kalpesh Shah, what's the practical experience of developing a stroke center? And I would like to ask, as Jaidas Ahmedabad has been a leader in developing innovative models. So we'd like to hear from his practical experiences, particularly how he uses AI in delivering this in real time in our country. Yeah.
Hello, am I audible? Thank you very much, sir. In 2019, the thought process of gaps and problems we have analyzed, we have done micro-analysis. And then come COVID. And then in 2022, we sit together with my colleagues and we realize 70% of the population in India is from the peripheral side, not in the city, main city, tier 2 or 1 or 3 city. They are most of the peripheral side. I am hybrid neurosurgeon doing open neurosurgery, micro neurosurgery, as well as intervention. Most of my neurosurgical patients come from the city, but none of the acute setting intervention patient, like stroke, hemorrhagic or ischemic patient, they are less than 10% or 20% of our practice. So I realize what is the reason? So we did a micro-analysis and we realized patient reach in time, almost 90% patient reach in time to the hospital after development of the stroke. Of course, very small, like posterior circulation stroke, only vertigo for a day, and then they develop the full-fledged altered sensorium. Out of that, only 10% people, they said we have not reached in time. 90% patient have reached in time, but they have reached in the hospital where the facility is not available, or even if the facility is not available, the doctors over there or staff over there could not identify the problem. So the problem starts of thinking what should be done. What is the problem? We understand, and now so that we made a pyramid. So how to target the area? First pyramid, the first base is the public, then the general practitioners and the non-MBBS people, then comes the physician, then comes the neurologist, then come the neurosurgeons and the neurointerventionists. So where should be the target? After thinking all the things, we realize that most of the patients are going to the peripheral hospital, smaller hospital, where we can say their name is ICU, but they don't have actually ICU. It's just made a room and monitor, etc. So we identify the problem. So we sit together at our hospital, and on 100-kilometer diameter, we draw the plan that within 1.5 kilometers, how many, from which areas or which hospitals patient can reach to our hospital at the 60 kilometer per hour speed. So we identify 10 centers, and then in 10 centers, 4 district and 10 centers, we went there personally to discuss with them that we can help you. We will train your persons. We will train you people how to identify the stroke, what kind of the treatment should be given. Mechanical thrombectomy is only a small portion. We are not here to discuss with you about mechanical thrombectomy, but the patients which are coming to you, they are not getting treatment in time. You should think about it rather than sending the patient for all the neuro patient you use in the peripheral ICU. They just send the patient to somewhere wherever they want to go. But ultimately, either patient go to government hospital or they don't, if they don't have money, as we have discussed so many times, either they go to another peripheral centers and never get the treatment. So after doing this, we invited all the hospitals we have selected. We have made the criteria that either they should have their own CT scan center or the CT scan center or MRI center should be at least 2 kilometers away from the hospital. And the hospital must have at least 2 or 3 intensive care specialists or MD physician. It's not only isolated physician. We have not selected the hospital which is run by the only one physician because he could not see the patient all the day and night. So at least 2 or 3 intensive care specialists who are running the so-called ICU. And then we've asked them to strengthen their, their efficiency about the identification of the stroke and the treatment part. So initially when we thought, we realized that if we invite them, they have to come. After doing at one date, we out invited them. Out of 10, only 4 hospital doctors came. So out of 44, only 12 people have come. Then we are depressed that this model is not going to successful. But after that, these 12 guys were really the ocean 12. They have asked so many questions. They were into the quality because retrospectively we understand they are self-motivated and self-inspired. So they have started the discussion with their colleagues. We have trained, we have given robust training to all the medical officers, staffs, and frequent training. 2 or 3 times we have given training, and we have taken the exam of MCQ. And then on the first time, they were not about giving more than 50% answer. But second time, after giving second training, they have given almost 70-80% answers. Okay. And then what happened? After this, they have started seeing the patients. And then we sent these guys to the periphery, in their own periphery. So the hub was our hospital. Spokes were these 4 hospitals. And these spokes were become hub for the next village style small hospitals. So it is hub and spoke is not the only one. It's like the spokes become hub gradually. Now, these people we have trained, they have started doing the thrombolysis. Surprisingly, initially they used to call us. We have installed the AI application in their CT scan center. We used to guide them manually on the phone. Initially, they used to do thrombolysis, but they were scary. If there is hemorrhages happen, what will be who will take the responsibility? So we told them that we are giving consent. It is our responsibility. You don't worry about it. Then they started doing the thrombolysis. So 3 consultants in the Idar and Mehsana, what surprisingly, they started doing thrombolysis in the CT scan only, in the CT scan, on the gantry only. And they are sending me the videos, and post, and they were happy. So then they gave the message to the villagers and the periphery. These are the magic drug. People are seeing it. Please give us a magic drug which we used to given to one of our colleagues so that our stroke can recover. So ultimately, they gain the confidence. The peripheral physicians and the intensive care specialists get the confidence of doing thrombolysis. And we have so far, in 1.5 years, they have done more than around 3,000 scans. We have scanned on our Cure app. Out of this, around 97 or 98, or approximately 100 thrombolysis have been done, and 35 in 1.5 years, over and above which we were doing in a hospital, 35 or 37 cases a year. First year we did 27 cases, and now this year we did 47 or 48 cases of mechanical thrombectomy in a year only. So it's a successful model. Only thing is we have to give robust training. of course, it's up and down. People, if you select 10 centers, only 4 will be ready. But ultimately, you will have your aim will be successful, and the problem which we are all are facing will gradually reduce. It's not we can make the system and they will follow the system. No, in the peripheral side, there is nothing like system because they don't have so much money to invest in a NABH style of working pattern, and this is the problem. So if we will strict work criteria, then it will be difficult for this spokes and hub. Of course, the spoke and hub and spoke is not for the metro cities. It is for the peripheral side. Most of the patient of the stroke are coming from the peripheral side.
Wonderful. So I've been Kalpesh, fully inspiring. And I'm sure there are a lot of us who will be in touch with you during lunch and later on.
Yeah.
Because I think there's so much more to teach because there is a difference between theory and somebody who has done it.
Yes.
And again, as you mentioned, Indian problems, how don't get dissuaded, few people turn up, you train them, they get inspired and they get better. And AI sounds like high-end technology, but I think it's absolute for our country because we don't have trained radiologists and time is the key. How to in peripheral centers. So AI nowadays, just to tell everybody, AI nowadays can diagnose a major vessel occlusion, can diagnose ICH. So we don't have trained radiologists, we don't have trained neuroradiologists, forget about neuroradiologists, right? So in India, we have to have much more AI than West because we don't have kind of trained personnel and they can actually mobilize and gives confidence that this patient can be mobilized, this patient can be thrombolized. And AI is going to play a more role and we should promote more and more AI usage. And as I said, Dr. Kalpesh has really did it on the ground, and I'm sure a lot of us later on can ask more questions and more discussions.
Yes.
And it is an
I have 7 points to say, only 1 minute. First point is we have in Gujarat, we have 147 centers. We have identified 147 centers for the CT scan and MRI. Out of this, 65 or 68, they can be directly equipped with the AI tool. They are directly connected with the good hospitals. So my suggestion is we should come out with the idea that these centers should be connected with the AI tool directly. Then 108 in Gujarat is doing wonderful job. There must be a different or separate dashboard for the stroke along with the 108. It's not the separate dashboard, it's somewhere else. 108.
This session. To go over some points.
Fine. So 108 dashboard and 108 application should be mandatory for everybody in the mobile. It should be like default. They should integrate with the Uber like services like Uber ambulances and also the stroke, NABH, etc. The dedication. There must be like stroke ambulance sponsorship. Most of the accident in India are due to manufacture automobile. The automobile manufacturers should be asked to have at least 5 stroke ambulances for each state, dedicated 5 ambulances for each state. And national level program looks funny to you, but it's a fact. AB, Amitabh Bachchan and KBC, like the platform, like, knowledge-based platform, they should at least ask 1 question each week about the strokes so that people will murmur about it and there will be good awareness about it. And then the other shows like popular shows should at least invite the stroke, those who have bedridden or people like somebody was telling me in the morning that Maharashtra government has done very good scheme. They should be like projected to the national level platform through the media. And the last is robust training of all smaller ICUs and in the peripheral centers is must. Thank you.
Absolutely. As I said, nothing beats a practical experience and nothing beats a passionate person who has done it. We can all feel his passion here and how much more we can actually learn from him, on the real ground. Thanks a lot, Kalpesh. I think there will be a lot more questions during lunchtime, even later on as well. Thanks a lot. So let us come to technology, and Mr. Gaurav is here from Philips India, and Philips has been at the forefront and of the healthcare technology. So how is IGT, or we call it image-guided therapy, is changing stroke care, and what role Philips is playing there?
So thank you, Dr. Vipul, for giving this opportunity to discuss on the technology piece, because when we talk about a stroke unit, and as Dr. Kamleshwar Prasad said, that we need to form a stroke unit. When idea of a stroke unit comes, so the most important part is when we talk about a stroke, is we said time is brain, right? So which means we need to save every moment of it. And the workflow becomes very important. And this makes it different from the other units that we have in the hospital. So workflow becomes very important, and that's the reason uh, we also talked about the other factors. In the morning, Dr. Mahajan talked about we need to treat the last patient in the society. So when there is a last patient, there has to be a first patient also. There has to be second patient also, which means there are different tiers of patient we are going to treat. In the hospital also, if you see, there are different hospitals. There is a tertiary hospital, there is a spoke hospital, there is a hub hospital. We all talking about how we can connect the hub to a spokes to a hub, right? So, and nobody disagree that hub and spoke model works very well there. But there are some tertiary centers also where patient is directly coming. How we can save a time there, right? The current protocol, if we have to learn from cardiology, I mean, if patient comes with a heart attack, he immediately moves into cath lab. But if you look at a stroke protocol, patient has to go through a CT or MR before getting into a cath lab. So this takes almost 25 to 30 minutes to 40 minutes of time, because you might have CT at different floor and then you move patient to a cath lab. It takes a lot of time. Now, Philips is supporting one study which is called VTrust trial, which is a multi-centric trial, randomized trial happening across 16 countries, which involves 3 continents and 500 plus patients, where we are trying to see if we can directly move patients from an emergency, from ambulance directly into cath lab. And cath lab technology can be managed in such a way where it will give you CT-like imaging. So you can save the 30 to 40 minutes, which is very precious for saving the disabilities and the immortality for the patient. So which means that because what happens in a patient with the stroke, it not only affects that patient, but also the entire family is getting impacted. If he's a earning member, entire family gets impacted. How we can even reduce the disability becomes very important. This 35 to 40 minutes becomes very important. With this direct to NGO suite, which is a new workflow that we are talking about, this will completely change the workflow of a tertiary center specifically. So on this front, I think this is where the technology is moving. So while we are trying to set up something on the base, we should also look at how we can set up the tertiary centers in a different way.
Thanks a lot, Gaurav. So if you realize, if I connect all these dots, we are talking about time. Hub and spoke for time, IVTP on time, and MT on time. What Kalpesh talked about training and everything transfer practically, we are talking about time. AI is based on time, quick diagnosis, quick treatment. And another time which we can have, that we have integrated cath lab, which comes called integrated imaging. What I would like to tell people is that we have got CT and even perfusion and CT angio built into the lab. So you avoid going to a busy CT scanner, as sometimes hubs can be very, very busy, and going directly to the lab, doing all that imaging and do it time. So these are all dots if we connect. One is building up a model, and within the models, how do we save upon time? Now, taking it further, talking about integrated imaging and using it, Gaurav. So can you tell what kind of partnerships we can have, or Philips is looking at what kind of imaging partnerships and to improve stroke care and make it faster?
So when we talk about the stroke protocol and we talk about hub and spoke, it's very important because you have one CD data. When patient comes with the CT scan and then he brings normally CD, you put that CD on a on the console of a cath lab, and then you go inside, and many times you don't have access those images inside the lab. What we are trying to do, we are working with the industry partners, with the companies who is in AI, and they are already there in providing a cloud solution. We are enabling our cath lab so that you can directly access those images within the cath lab. So you can avoid getting into CD, look at the data. By the time the patient is coming in the cath lab, you are already ready because the alert is already gone to the doctor and lab is ready by the time patient comes in. The moment patient comes in, and you, instead of looking at the data outside and then go inside, you can directly start a procedure and you can see those images on the cath lab itself. So we are integrating both the companies which is providing the hub and spoke model with the server, and then along with the cath lab. So this will also further improve your overall workflow.
Wonderful. In this world of that everything has become smaller, we are talking about imaging of a digital center available in the cath lab, not in a monitor, in your even therapeutic monitor. So this is happening real time, whatever you're doing. And again, you're cutting down on the time, and all these solutions are now available and executable as well. And I said, this may sound high-end technology, but India, we need it more because we are less trained, officially trained professionals. And it's great all of this is happening, and we ourselves have benefited already over using intra-op imaging, cross-section imaging during the procedures. Now, a lot has been talked about AI, and it's a great pleasure to have Dr. Tamangna Ghosh from Cure AI here. And of course, we also, when I was at Artemis, we established hub and spoke model, and using Cure, and I was still working pretty well. So, but okay, so as I mentioned a little bit about AI, but AI has no limits, right? It's pretty exotic, right? Every day we heard something new. So please tell us how we are taking AI forward in terms of stroke management, whether imaging or whether there is some news about neurocritical care softwares in AI, and which maybe can be used in stroke ICUs. Again, we don't have, as I said, training people for management is so challenging, and whether we can use AI to supplement it. So can you tell us what's the future like?
Yeah, thank you so much, sir, for the question. I mean, we've had the pleasure of working with you, with Dr. Kalpej. I think in the last 2 years, we have been deploying AI-powered hub and spoke models, and we are now present in more than 40 sites. And through that, we've had some learnings, right? We've realized what some of the barriers are. Even if you have the technology, it doesn't mean that everything goes according to plan. So some of those challenges that you've seen is, as Dr. Kalpej was saying, that many a times the patient is actually coming in time to the spoke, but the transfer from the spoke to the hub site itself is adding to a lot of delay. And most of the delay is because of the complexity in the decision-making process. So it's not just about the patient symptoms or the imaging, it's also about the financial condition, etc., etc. Right? So that was one thing that you have learned. And the second thing that you have learned is even if the patient is within a window period or may likely to benefit from therapy, there's a lot of hesitancy in the first-line physician in actually implementing thrombolysis or transferring the patient for thrombectomy. So the advancement that we have been focusing on at Cure to take the hub and spoke, AI-powered hub and spoke to the next level has been towards doing more with less, right? It's about taking less resources, less time, less manpower, and yet being able to deliver the same amount of value. So one of the things, which is the first one, which is delays from in the transfer from spoke to hub, and hopefully the patient doesn't, reaches in time. And so trying to solve that, we have now worked with multimodal models. So earlier AI was only about interpreting, making a diagnosis, looking at CT scans. Now we are talking about multimodal models where it can take disparate pieces of data. Simple clinical information like what is the age of the patient, what is the gender of the patient, right? What is the last known well time? And you also give the model the non-contrast CT scan, and then it's able to predict what is the likelihood of the patient actually undergoing mechanical thrombectomy. So why is that important? Because that means within seconds at the spoke site, when the patient reaches and CT scan is done, there's already a probability that is calculated on what is the likelihood of this patient actually reaching a neuro ICU or having a transfer required, right? So that thereby it can actually reduce the time for the clinical decision to actually transfer, and maybe even automate the process. The second thing that we are working on is, again, playing on the principle of doing more with less, is that we see that one, again, the physician confidence and the low physician confidence in actually treating, even though hemorrhage has been ruled out on NCCT, many a times they're waiting for an MRI or advanced imaging to confirm that infarct is present, though it should not be done according to the guidelines. So we wanted to bring that confidence back to the physician. So what we have now is actually being able to identify not only the infarct core, but also penumbra. So at-risk tissue, which is hypoperfused, which is still salvageable by any kind of therapy, that being identified just on NCCT. And if we have that, that also means that your hospital does not require any advanced CT scanner. It's already something that we can implement and augment in existing infrastructure. And AI can actually help you identify such cases, even if the patient is beyond 4.5 hours or just beyond 24 hours. But if you are seeing that there is penumbra, then these patients can be transferred in time or even given thrombolysis. So these are the two aspects that we have been working on in terms of it.
So again, as I said, AI is going to transform and probably as we laid out and with our limitations of trained personnel and evolved hospitals, maybe we should use it more and we have Indian solutions here. Just to conclude now, one line, we talk about Make in India and it's great to have our indigenous AI model. What in one line, can you say one particular challenge you are seeing in terms of acceptance or more hospitals taking it over? I mean, anything practical?
Yeah, I think
one line.
Very briefly, it's the cost of acquiring an AI does not pay off immediately. It's something that the hospital kind of accrues back over a period of time, and that is a barrier to adoption. So today, if we really want to scale up AI, again, if it is included in insurance, if it is included in Ayushman Bharat as something that can be reimbursed, then the uptake is going to be much,
Yeah,
much
absolutely right. In fact, when first Interop CT, not Interop that, it was a, I mean, Angio CT in the lab. I was in Max Hospital. The only way I could get it was that I said, okay, we'll bill every patient. Post-op CT, we'll bill it and to make it practical. So we have to look at innovative solution, how hospitals can acquire this technology and slowly we can pay and build into the billing model. So I think this has been a terrific session and we have all the experts here. So if you realize, we have built a single model. It's not a single model. We talk about stroke delivery model, as Dr. Kameshwar Prasad mentioned, having a stroke unit with simple ideas, keep monitor these four things, and simple prevention of BP plays a more role. And within the stroke units, we can have accreditation, which comes in, which really increases number of patients getting treated and quality of care, and public also accepting the model. And of course, this all has to be built on hub and spoke. That's the only way to happen. And practical problems which we are facing, which Dr. Dheeraj Khurana laid out, but all this high tech has to be built with peripheral outside the hospital rehab. There is no point we are focusing on medicine and AI and technology and forgetting the really key, which later on can improve this patient. And Dr. Kalpesha showed us how on ground all of this can be done. So we have no excuse any longer. We just need his kind of passion and ideas, and we can learn from him.
So, Dr. Vipul,
Yeah.
just a myth I would
Yeah.
like to, Dr. Kalpesh felt that accreditation is expensive. So just for record, our standards cost 11,000 rupees for 2 years. And in just 11,000 rupees for a primary center.
In fact, that has got me worried now. Thanks
Yeah,
for
yeah.
bringing this up.
11,000 rupees for 2 years, and in that you get two logos, one of WSO and one of NABH.
this is
And these
great.
are totally Atmanirbhar,
You
self-reliant.
and I, you should look at this kind of financial standards as well. Okay. and and of course, how technology makes it faster. As Phillips mentioned, Interop imaging and AI. So all this is one single model, actually, if you see. And if authorities are listening, none of them cost too much. They're all cost efficient. They're reducing the cost overall to the society rather than we're talking about very high-end technology or very expensive models. It is just having a smart model on ground. Thank you. Yeah.
We will break for lunch. Lunch is in the third floor, and we will come back for the last session at 2:45. Sorry, for the next session at 2:45 p.m.
Hello. Signe, can you hear me? Oh, she's still connecting. Okay. Sure. Signe, can you try to speak now? Just unmute yourself.
Can you hear me now?
Yeah, it's working.
Okay. Okay, great. And is the sound good?
Yes, it is. Can you also try?
Okay. And yeah, I'm going to share my my presentation. Let me know if you can see it.
Yes, we can.
Okay.
You'll be able to zoom it, right? This is working well, Signe.
Sorry?
This is working well. We can
Okay, good. I'm glad.
see you in the little window.
Okay. And I'm going to advance a few of my slides, if that's okay, just to see if it's working correctly.
Yes, it is.
Okay. All right, great.
Hello, Signe.
Hello.
How are you? Sorry, I just came to know you couldn't make it here. We'll miss.
Yes, I'm so sorry.
Yeah.
Hello, everyone. I welcome back everyone from the break. I hope you had a hearty lunch. So now, right now, we are going to have an address on the public-private partnership in education, research, and implementation by Ms. Signe Horton. She is Chief of Staff, Senior Director of Medical and Government Affairs, Medtronic Neurovascular, and she has joined us all the way from US. Thanks, Signe, for joining us today and sharing your valuable insights. Moreover, she is a medical device executive with more than 25 years of experience at Fortune 500 medical device industry-leading companies. She has spearheaded numerous impactful initiatives that have influenced stroke therapy worldwide, and she is going to share some insights with us today. Over to you, Signe, now.
Thank you very much, Ayushi. I would like to thank Dr. Pandya and all of the delegates at the FICCI and the Medtronic India team for the invitation. And I regret that I'm not able to be there personally. I'm very sorry for that, but I appreciate this opportunity to share with you some of the initiatives that we've been working on in education, research, and implementation to drive stroke treatment forward. So thank you for the invitation. As Ayushi mentioned, I am a Medtronic employee. These are my disclosures. And I'd like to begin by first taking you back almost 10 years ago to where when the 5 stroke trials that led new street treatment guidelines from the American Heart Association were first published and implemented back in 2015. And if we look back on the last 10 years, although these were revolutionary stroke trials that really implemented important change for stroke, we have certainly not come as far as we would have liked to have come 10 years later. And so I think this is where we all appreciate the opportunity to more closely focus in on stroke. And I'll begin by sharing some of the statistics. In 2023, in case you had not had an opportunity to see, the Washington Post actually published an important article that addressed stroke and the deaths associated with stroke and how those might rise by 50% by the year 2050, as predicted. And if we take this a step further and look at how the importance of stroke as part of the non-communicable diseases that are addressed annually, as we all know, 41 million people die from these NCDs annually, which is equivalent to about 74% of all deaths globally. And from that, cardiovascular diseases account for most of those NCD deaths. If you look at the coronary artery disease and how that has been eligible patients for treatment for coronary artery disease is certainly far greater than the eligible patients for stroke and the attention that stroke is getting in terms of that disparity between CAD and stroke. And so this is where we have been focusing most of our action plans to address this disparity. If we take that a step further and look at the disparity in the available mechanical thrombectomy access to treatment worldwide, as you can see, obviously by income level, the higher income countries obviously have higher penetration rates for access to mechanical thrombectomy, and the lower and middle income countries have far less. This enormous disparity between the country levels is then indicated below for you here. And you know, these are the significant determinants of mechanical thrombectomy access and the attention that each country per capita gross national income is being given to these access levels. And many of the areas that we're focusing on is obviously pre-hospital, LVO, large vessel occlusion triage policy, how many mechanical thrombectomy operators there are in each country, and centers that actually offer comprehensive stroke care treatment. If we take that even one step further and look at how the cost to society is being burdened by stroke, you'll see that this is the economic cost of stroke back in 2017, which was equated to be about $912 billion, which is now expected to grow to more than $1.6 trillion by the year 2015. So this is obviously a widening gap that is also associated with the disparities between lower middle income countries and higher income countries. One way we need to potentially address stroke and how stroke is being recognized globally is, do we need to start thinking of stroke as a global pandemic? If we think about the official death toll as reported by the World Health Organization, COVID-19, the estimated death toll was about 3 million people globally. If you compare that to the 6 million people that are affected by stroke every year, we need to start thinking of stroke as a global pandemic. And I think that's the attention that it requires. If we look at specifically the official death toll in India for COVID-19, you'll see the statistics there according to the World Health Organization dashboards. What we do know is that the annual death toll from stroke in India is estimated to be around 55 deaths per 100,000 people based on most recent studies. And this indicates a significant burden of stroke-related mortality within India, with the overall stroke death rate increasing from 44 per 100,000 back in 1990 to now the 55 deaths per 100,000 back, which was estimated in 2021. We know it's the second most common cause of death in India. The incident rate has been increasing over time, and the mortality rates can vary significantly across different regions of India, with the Northeast experiencing the higher rates. And most recent studies show a considerable case fatality rate for stroke in India, meaning a significant proportion of people who experience a stroke actually die from it. So knowing all these statistics, and if stroke is so treatable, why aren't patients being treated? And this is one of the many things that we've been focusing on through various partnerships with the World Stroke Organization, with the World Economic Forum, with our partnership with Philips. But it really can be answered in the fact that there's a real lack of awareness of stroke symptoms, stroke treatment, and the timeliness, the importance of timeliness to treatment. There is a real lack of developed systems of care to effectively triage suspected stroke patients to the right treatment hospitals. There's lack of infrastructure within the hospital centers, such as imaging, such as labs, such as employee staff. There's a lack of trained physicians that know how to treat stroke and perform mechanical thrombectomy. And then from a social perspective, there's a lack of awareness of the societal and economic impact of stroke and the potential human and cost savings that can be achieved by developing real stroke systems of care. So many of the areas that we are focused on through these partnerships is to build sustainable healthcare systems through research and data. As we all know, there's been an extremely important study performed in India that has led to recent changes for the positive. Developing market support, making sure that the public is more aware of stroke treatments, accessibility to treatment, reimbursement and national guidelines, and capacity building, such as making sure that we have enough training and stroke center certifications to ensure that the population of patients with stroke can actually be treated. And so that's what I'd like to take you through a little bit more now with regards to some of the partnerships and advocacy and helping to expand the access to treatment. I think, as was mentioned earlier today, I think there was a presentation on the partnership that Medtronic has instituted now with Philips. And we feel that having the voice of Medtronic and Philips together as a true partnership will provide a bigger and greater voice for accessibility to stroke treatment and awareness of stroke around the world. So we're supporting the World Stroke Organization Advocacy and Coalition launch at the World Economic Forum through a blog this year. We are co-hosting a side event that's also focused on the stroke impact at the World Health Assembly. And we most recently co-hosted an event at the United Nations General Assembly in September of 2024 in New York, where NCDs were the main focus topic. And that led to an important advocacy roundtable also at the World Stroke Conference as well. Philips and Medtronic have also been co-presenters at the Global Stroke Alliance last year, and that will continue into 2025 as well. And we will continue to partner and support lower and middle income countries that are focused on developing stroke networks and helping to boost those advocacy efforts and educating healthcare providers worldwide. And I'll take you through an Indonesia case study a little bit later, but these are some of the initiatives that we are focused on and will be developing in Mexico, in Southeast Asia, and in the Caribbean. We also have a partnership through an implementation of a society and industry-led coalition known as the Global Neurointerventional Coalition, which I started back in 2015 when the stroke trials were first announced. And that GNIC partnership is associated with the Society of Vascular and Interventional Neurology, mechanical thrombectomy-driven consensus paper that we have been focused on, which will hopefully increase access to mechanical thrombectomy and training of the workforce as part of the GNIC. And we will also be working on providing observerships and proctorships in association with the industry and working with the World Stroke Organization Advocacy Coalition as well as some other partnerships with some of the other neurovascular societies around the world. This is some of the press that we have received recently through the partnership with Philips. We're very proud of those partnerships and has allowed us to really help bring stroke to the attention of the world. The case study that I mentioned earlier that I'd like to take you through is in Indonesia. And just to provide a little bit of background, as we all know, Indonesia is made up of about 280 million people, with that population expected to increase by 14% by the year 2050. Indonesia consists of 17,000 islands and is considered an upper middle income country according to the World Bank income level. They currently Their current health expenditure is about 3.7% of the GDP as compared to 3.3% of India. In 2020, stroke accounted for a little over 20% of the total deaths in Indonesia, which ranked Indonesia the 11th globally for stroke mortality. And I think that's really important to share here. And ischemic strokes actually constitute more than 65% of all stroke cases in Indonesia. And the two major factors that are leading to that stroke burden in Indonesia is the insufficient number of stroke-ready facilities. Only about 12 of the 33 provinces in Indonesia actually perform routine mechanical thrombectomy and neurovascular procedures. And the lack of treating physicians in Indonesia is also very low. The number of interventional neuroradiologists is only present in about 24 out of the 33 provinces in Indonesia. So the target here was to really create a stroke care transformation program in India. And this was a health system transformation initiative that was started back in 2021 to reduce stroke-related mortality and disability by enhancing the health system's capacity to deliver timely and effective stroke treatment and prevention and rehabilitation services nationwide. And so the key program components of this initiative in Indonesia was first to strengthen prevention of stroke in Indonesia, and then to establish a stroke referral network within the country, create greater access to thrombolysis and mechanical thrombectomy, to create more stroke centers nationwide in India, including rehabilitation services. Digital health and data integration is a big piece of that as well, and the partnership and advocacies such as with the World Stroke Organization, with Medtronic, and also with Philips. And the main target here is that by instituting this transformation program by 2028, the goal is to have all 33 provinces in Indonesia with a secondary level hospital, meaning offering both neurosurgery, endovascular treatment, and clipping in all, and having all 507 districts with at least one primary level hospital that can offer both thrombolysis and thrombectomy within those centers. So that's one of the transformation care programs focused on stroke that we are focused on constituting and instituting in a lot of lower and middle income countries worldwide. And so by strengthening prevention, creating stroke referral networks, having greater access to endovascular therapy, developing advocacy programs, and increasing workforce capacity building and stroke centers is how the PPVs support these transformations. And so all of these are important initiatives in terms of driving stroke care forward. The Global Neurointervention Coalition is another thing I'd like to just quickly mention. It's a global collaboration that was created back in 2015 after the 5 stroke trials were first published. That is essentially a coalition made up of all of the industry partners and all of the global neurovascular societies around the world that is dedicated to advancing neurointerventional treatment and fostering knowledge, promoting research partnerships, and establishing best practices for neurointerventional procedures worldwide. Most recently, in 2023, we had another meeting that was joined by 10 medical society participants and industry collaborations as well, in which we are creating a consensus paper on meeting the twin challenges of global thrombectomy access and workforce training worldwide. So this is going to be an important white paper that will hopefully be published very soon and shared with all of the global neurovascular societies around the world. As I mentioned, we had the opportunity to present at the United Nations General Assembly back in September. Dr. Fawaz Al-Mufti, who is part of the Society of Vascular and Interventional Neurology, joined us there as well. And we were joined by ministers of health, representatives from seven member states, and discussed the disparities in stroke and the mission to drive this forward. The Global Stroke Alliance is another partnership that obviously we've been focused on. Dr. Pandian has been a part of this as well as Professor Sheila Martins, who's the president of the World Stroke Association. And so this is a partnership that continues and helps us to create that awareness of stroke through the partnership with Philips as well. One of the other important things that we've been instituting in lower and middle income countries as well is the mechanical thrombectomy workshops in association with our society partnerships. We've held them in Jamaica, in the Dominican Republic, in Colombia, here in Italy, and most recently in Istanbul. And this is opportunity to allow physicians a greater awareness of mechanical thrombectomy. But obviously, by hosting these types of workshops, you also want to understand that there is real impact from this. And most recently in the stroke publication, there was a publication by Professor Sheila Martins and Dr. Violisa Inoa that demonstrates how these types of workshops are actually having impact in these lower and middle income countries in terms of driving awareness. And then I'd like to just quickly end with the most recently World Stroke Congress, which was held in Abu Dhabi, in which we had a fireside chat with Dr. Violisa Inoa and Dr. Sheila Martins, and also a dinner that was hosted by Medtronic and Philips to advocate for global equity in stroke care access and quality. So I'd like to end with our main goal, which is to continue to ensure that stroke is foremost in the minds of the world, with the final goal of hoping to have stroke on the G20 agenda, which will happen later on this year. And so I want to thank you for this opportunity to present here, and happy to take any questions.
Would like to thank Ms. Signe Houghton for all the remarks and welcome note. And with this, we start with the third session that is mainly on the state-specific practices in stroke care, which will give insights and future directions. So I would like to welcome all the dignitaries on the dais. Dr. Jairaj Pandian, who is the President, World Stroke Organization, Professor and Head Neurology, Principal and Dean, Christian Medical College, Ludhiana. Dr. Syed Abid Rashid Shah, IAS Secretary, Department of Health and Medical Education, Government of Jammu and Kashmir. Dr. Shikha Vardhan, ADG, Ministry of Health and Family Welfare, Government of India. Dr. Avnish Kumar, Director, Department of Research and Medical Education, Government of Punjab. Dr. Vipin K. Gopal, Deputy DGS, State NCD Division, Government of Kerala. Dr. Jacob Johnson, Christian Hospital, Tejpur, Assam. Dr. B. Naresh, who is Executive Officer, Rajiv Arogya Healthcare Trust, Telangana. Dr. Swapnil V. Lal, Director of Health Services, Urban Maharashtra. Dr. Arpita Garg, Senior Medical Officer, Ambala City, who's joining us virtually. Good afternoon, everyone. And now I would like to hand over the session to Dr. Pandian for all the further discussions. Thank you, sir.
Thank you very much. Let's start the session. The context is in the morning, we had two sessions looking at the barriers, facilitators of stroke care globally as well as within the country. But in this session, we are going to focus on individual states, and we are going to learn from different states, the current model that is ongoing. And so there are several states that have been represented here. So first of all, I will start with Dr. Syed Shah to give his virtual presentation about his experience in Jammu and Kashmir.
Am I audible?
Yeah.
I can't hear you. Am I audible?
Yeah, we can hear. Yeah.
Yes, sir, you're
Yeah.
audible, sir.
Thank you. Thank you very much. Dignitaries on and off the dais, a very good afternoon to all of you. Speaking to you is a bit of a challenge because I'm speaking to medical luminaries. And as Secretary Health and Medical Education and once upon a time doctor, it is quite frankly a privilege to speak to all of you. You're going to discuss the technical aspects of stroke management. You're going to discuss the whole concept of new modalities in stroke management in our country and across the world, learn from best practices. But I have slightly different take on this. In my own presentation of around about 10 minutes, I'm going to highlight the social aspects of what we are dealing with on a day-to-day basis. Number two, I'm going to highlight what we have done in Jammu and Kashmir with regard to some specific interventions in stroke management, which could be looked at in terms of implementation as, if you know, best practices. In terms of the social aspects, the dynamics of stroke. Now, it is very easy for us to deliberate here. Now, while I really appreciate what you're doing here in terms of an intervention for policy change, making the structure of healthcare systems, especially public and private healthcare systems, more amenable to this concept of stroke management. But there's a massive cost to this. The human cost of stroke in our country, as in our union territory, is very high. Every single year, we see somewhere, and I'm talking of public hospitals, government hospitals alone, we are talking of somewhere around 15 to 16,000 patients who present to us every single year, largely with hypertensive strokes. There's a massive human cost to this. There is physical impairments, be it hemiplegias, aphasia, dysphasias, fatigue. There is a massive emotional element to this, cognitive and emotional element to these patients, memory loss, confusion, depression, anxiety, massive personality changes that we have seen in our own healthcare system. There are health complications, reduced life expectancies. There are social dimensions to this, and the impact in a country like ours on the family and the caregivers, who largely undergo a massive financial stress giving that kind of care. And then there is a massive structural change in the altered family dynamics where roles and responsibilities are changed. The head of the family undergoes a stroke, and then suddenly everything in the family shatters. Besides the economic consequences, may I add, which are sometimes most lethal to people who are from a lower socioeconomic strata, where they are unable to return to work, where there is massive loss of productivity, and so therefore it becomes a cascading effect. There's massive social isolation. There's a stigma attached to a patient of even today, to a patient of stroke who is unable to move, who has quadriplegia or hemiplegia. There is reduced abilities, so therefore the ability to earn his own bread becomes a massive hit. And the broader social costs on the public healthcare systems, where you have to make sure that you, in terms of the disease burden, accustom your own healthcare system, and so you have to have funding for that. These are some of the major strike points of what stroke does to our healthcare systems day in, day out on a yearly basis. And so therefore, today's event is extremely important, and I am glad that we are discussing this. In Jammu and Kashmir, because there is massive, we are faced in the country with like in the rest of the world, I would refer to this as a pandemic of non-communicable diseases, of hypertension, of dyslipidemias, of a bunch of other stuff in terms of this, and which all contribute towards strokes in one way or the other. What have we done with regard to stroke management in Jammu and Kashmir, and to undo the damages, and most importantly, how to go about doing this? Jammu and Kashmir has adopted a holistic approach to the stroke management in the healthcare system, where you will be surprised to know that thrombolysis takes place even in our district hospitals, some of the most remote district hospitals in Kupwara, which is just a stone throw from the line of control, does this procedure. So therefore, the healthcare system is really well geared up to manage stroke patients. Besides that, we have operated the concept of hub and spoke in stroke management, wherever we have government medical colleges, and we have 10 of them across the length and breadth of Jammu and Kashmir. The PHCs, where invariably the first presentation of strokes takes place, and in a geography like J&K, which is extremely difficult in terms of the terrain, we operate this hub and spoke model where the hub is the government medical college and the spoke is invariably the community health center or the primary health center. And so if there are referrals required, that is done. Like I said, thrombolysis is done even at the district levels in the remotest of districts in stroke. In Medical College Srinagar, which is the super specialty of Kashmir Valley, every Friday there is a stroke clinic. So we have a designated day for stroke management. It's a stroke clinic where we deal with patients, where we deal with families of patients, where families of patients are counseled. We invariably do not take that factor into account, but that is a very important part of the management cycle of this disease that we must look into in both government and private institutions. At the community level, what we are doing is involving the community health workers, the ASHA workers, and all such other allied healthcare workers who are part of the community in terms of spreading awareness as to how to prevent this disease. At the sub-district hospital level, the physician-led care is most important, and so therefore referrals from the community get arrived at the sub-district hospital levels and then escalated to the district hospitals, and if need be, to the tertiary care hospitals, which is the medical colleges and SKIMS, which is an institution of ours. The government of Jammu and Kashmir facilitated a wonderful initiative which was called the Save Heart Foundation, which saved hundreds and thousands of human lives, where doctors and primary caregivers in most peripheral health institutions made a WhatsApp group, which is called the Save Heart Foundation. On the same analogy, there's something called the Save Brain Foundation. We are now trying to replicate the Save Heart Foundation with the Save Brain Foundation, in which the tele-management of strokes is done so that somebody sitting in a higher center, let us say a medical college, can handhold someone sitting at the sub-district hospital level. One of the best things that could lead to better management of strokes was the Sehat scheme. We have universal health care for the entire population of Jammu and Kashmir, universal health insurance to the tune of 5 lakh rupees for every person domiciled in Jammu and Kashmir. That has been a complete, absolute game changer in the management of stroke, because like I said, the financial burden of stroke is so high on patients, and particularly in patients in lower socioeconomic stratas, that this scheme has proved to be a complete game changer. In times to come, we must possibly think about new modalities of treatment of stroke. We must possibly deliberate from research levels down to ground level implementation, because that is what we are dealing with on a daily basis. We must probably think about portable imaging technology. Not every place has an MRI, so probably MRIs could be made portable. Something has happened in the Yale University. Maybe we can replicate, maybe private players and the industry can think about something of this sort. We don't have CT scan machines everywhere. Maybe something of portable CT scan machines can be worked out. We really do not have a very robust digital rehabilitation system. We must probably think of that, and the industry must definitely look into this. Most importantly, we also must think about, probably at an industry level, of early intensive rehabilitation, of how to create equipment, how to create better uh, equipment for early rehab, early management of the stroke. Besides other things, which will, I am very sure, percolate down to the ground level implementation in the next 5 to 10 years, stuff like neural stem cell therapies, stuff like vagus nerve stimulation, stuff like advanced research and development of stroke, which is currently taking place in some of the best universities in the world. I'm very certain in the next 5 to 10 years, we should have some kind of research and development which would help us in one way or the other in the management of this grave disease, which causes all those social and economic and emotional aspects of literal turmoil in a patient's life, including his family. What we must probably conclude, and I'll conclude my presentation on this, what we must look at is probably one way or the other in which we take a holistic approach towards stroke management, holistic approach towards management of such disease, taking on board the healthcare systems, which invariably sometimes work in isolation, healthcare systems with the families in public hospitals, in public healthcare systems. Taking on board the families is most critical. Invariably, we don't do that. We do that quite a lot in the private establishment, but we don't do this in public because of the burden of patients and the footfall, mere footfall of patients, which comes to the tune of somewhere around 201 OPD. It's very fancy to say we must probably counsel the family, but we need to have some specialized mechanisms at a policy level to ensure that a holistic approach involving the healthcare system, involving the families, and most importantly, involving the community if we have to prevent the adverse implications of stroke. Thank you very much for giving me an opportunity to speak to all of you. I look forward to picking up some of the best points that the other states and the other experts have pointed out. I would also request the organizers to have some kind of a rapporteur-based point made out so that they are shared, these points are shared with us, of whatever is applicable to us, whatever is implementable at a government level. We will ensure that that is taken up. And on behalf of the Health and Medical Education Department, Government of Jammu and Kashmir, I would like to congratulate you once more in the end, and I would look forward to further engagement with you at a policy level in order to decrease the burden of this scourge of strokes on our population. Thank you very much.
Thank you, sir, for giving us an overview of what is happening in J&K in terms of stroke care. We are very pleased to see the progress in terms of thrombolysis being offered in district hospitals, a hub and spoke model, and a stroke clinic as well. And it's very interesting to see the Save Heart and Save Stroke Foundation, Save Brain Foundation, and these are some of good examples that other states also can use. And of course, we'll be able to help you in any way if you need, particularly in terms of research, training of healthcare professionals, even interventionists, and also rehab. And thank you, sir. And with that, we will move on to the keynote address by Dr. Shikha Vardhan, ADG, Ministry of Health and Family Welfare. She's going to share with us about the programs that are ongoing under the Ministry of Health and Welfare and how stroke care can be scaled up in the program. Thank you.
Thank you very much, sir. And rather, I would like to thank organizer for organizing this important meeting and means great honor is to all the dignitaries who are on the diet as well as off the diet, because you all are the experts, you're the esteemed experts in your field. And rather, being the program person, we actually, this program is actually working based on the knowledge which is being imparted from you people. And as you know, the NPNCT program has seen a journey over the years, and stroke is a recent inclusion wherein a guideline was being framed over there. And still, we are still in the revising phase as per the available information or the evidence which is being generated. And Dr. Pandian, he is, I think, beside me, he is one of the technical expert group for drafting that guideline. So primarily, as for the non-communicable disease program, if we consider, usually NCD is being considered like the chronic disease, which is over the time, which degenerate through the common risk factors, which includes that dietary lifestyles, as well as the hypertension, diabetes, those metabolic disorders, and then leading up to certain illnesses which are having the acute impact. So under the program, the acute impact which is being listed under the NPNCD is the cardiovascular disease, STEMI, and as well as the stroke. But the issue is, excuse me, but the issue is because of the infrastructure which we have, any public health program is actually run through the demand which is being created by the beneficiaries, and then accordingly the finances and the resources are being employed for that program. So for the stroke, we all recognize that this is an emergency and we need to have to address it on priority basis. But the thing is, we still lack these statistics, because those who are being diagnosed with the stroke, either they are not being treated properly or they are not being listed, and then afterwards, or even if they are being treated, they are not being reported. So we are actually having means not the appropriate statistic. And again, these stroke cases may vary in various parts of the country. The region specific, we want the exact figure, means why certain states should pay more attention to address the situation. So we don't have that rationale as of now. But still, we are trying our best based on whatever the data statistics we have. And still, I think some global burden disease are being calculated, and because of some projections, which might not be the actual figure. But again, here the program is taking all, means whatever information we are having, we are just considering all. And other thing is, under the NPNCT program, we have the National Multi-Sectoral Action Plan 2, wherein 39 ministries have already been listed. And as we say, NCD, even the stroke, they have the common risk factors. So these risk factors, if through these various departments or the ministries are being addressed appropriately and timely, probably many things will see a better future. Like if I take an example of the Ministry of Road and Transport, if they work, they prepare some corridor for the ambulance movement, for the acute emergency, or some other measures are being drafted, so that the ambulance, if we say this, although I'm shifting, if I just take an example of Delhi, although corridor are there, but these are being encroached, or these are being utilized by other vehicles, so ambulances are not given the space. And that too, even if patient is being diagnosed with a stroke, that patient doesn't reach on time. One thing is this. And before coming to that, I would like just to emphasize, again, we are saying again and again, we are saying that we have to build comprehensive stroke units. Here I would like to say, government means not talking means negatively, but yes, the infrastructure as of now is means having the limited resources in terms of the infrastructure, in terms of the manpower, in terms of other things. So we have to utilize whatever is being available. So in that way, in seeking best, we are means ignoring the better one. So one here, because this session is regarding the states, So my urge to all the state is because health is a state subject. So what I believe is every state should take an initiative at their level so that they just identify at whether government or the private, the hospitals, whether the tertiary care hospitals or the medical colleges, which they can label as a hub, there the capacity building can be taken, because creating a new thing is really difficult. And yes, we can, although some equipments or some other things might be required, so they can just list out their what are their actual requirement, and they have to justify it. I'm saying justifying because during the COVID time, if I think many of you might have realized, there were ample of donation by the various organizations, and they were just lying like in ventilators. They were just lying at the side of a hospital, not utilized. Patients were there, but still, because people were afraid, how do you operate it, or they were not sensitized properly, so they were minimally utilized. It was really pathetic to see, why people it has already gone out of the AMC also. Even they have not opened it. So that's why I'm saying they have to list out what all they require, and accordingly they have to, that need assessment has to be undertaken by individual institute or the organization, and they can send the demand, what exactly they want, whether they want a capacity building, whether they want some specialized equipment or the machine or something with the rationale, and accordingly the things can be taken up. It's not think that government is denying anything. You have to put your demand in, right? And the other thing is the spoke thing. Everyone has told us spoke, but spoke is like if a medical officer is sitting in the periphery, if that person is not being sensitive or being overburdened, or somehow in certain states the private practice is being allowed, so that person is not available for some reason. So again, we are missing that patient. So we need to make our community enable for that purpose, so that whosoever be fast is the mnemonic being given. So it has to be actually all should be sensitized for be fast. What actually is the be fast? So that basic communication needs to go right from the very early age. Rightly pointed out in the morning that school children, youth, they should be engaged for this purpose, and the frontline worker, they should be trained further, and some incentivization can also be considered if in certain conditions. So that is the thing, because we are and again coming to the state again. So when the state is being planning all this, when they have mapped the thing, their infrastructure, their manpower, everything, so they can plan their stroke units, and hub and spoke model can be implemented. And then accordingly for the drugs and logistics, they can put the demand in their PIP. So our program runs through PIP, program implementation plan, through NHM. So they can put the demand, and there is no chance if someone provide the rationale, they will be denied. So rather one has to be as rightly pointed by Secretary Sir before me, that one has to have the holistic comprehensive approach, wherein everything should be taken care of, and whatever resources you are available, you are having, just utilizes perfectly. At you guys. Thank you.
Yeah, thank you, Dr. Shekhawardhan, and highlighting how the processes that are involved for state governments to identify important hubs and how they can develop the spokes, and also the mechanism of asking for funding for some of the important needs that they have specifically. And I think this probably the state government should utilize these opportunities. And as part of NPNCD program, stroke units are they have funding to start stroke units in district hospitals, including infrastructure. Everything is listed, and it is up to the state governments to start this initiative. Thank you, Dr. Shekhawardhan. And let us move on to the panelist here. I would request the panelists to answer the questions in brief, maybe 3 to 4 minutes each. First question is to Dr. Avnish Kumar, who is the DRME from the government of Punjab. I've been involved with the government of Punjab, and our initial discussion about starting a hub and spoke stroke program in Punjab, and what are the learning things from the Punjab hub and spoke model, and you can share so that others could benefit. Sir.
And the Punjab stroke model exemplifies an innovative and collaborative approach to addressing a critical healthcare challenge, that is stroke management, through a public-private partnership. This is being done with Christian Medical College, Ludhiana, which is in the center of Punjab, with the government of Punjab and with Medtronic. And trust and faith indeed form the foundation of such partnership, enabling seamless cooperation between government machinery and private hospitals. This model not only highlights the strength of collaboration, but also serves as blueprint for sustainable healthcare delivery. So why it stands out? It is because it is a hub and spoke framework. It is based on hub and spoke framework. The integration of hub with various spokes ensures a decentralized yet coordinated approach to stroke care. The structure improves accessibility for patients across regions. The Ludhiana is in the center of Punjab, and any patient from anywhere Punjab will take 3 hours to reach Ludhiana from the farthest point even. Then AI-driven ecosystem. There is incorporation of an AI solution for real-time patient tracking and clinician reporting, which is a game changer. It minimizes delays in diagnosis and treatment, helping ensure that stroke patients receive timely intervention within the crucial window period. Then rolled vision and mutual learning. The government directly manages thrombolysis while Christian Medical College handles interventional procedures. The division of responsibilities fosters mutual learning, building capacity for eventual self-sufficiency of government hospitals. Ultimately, these spokes will also become hubs. All the medical colleges will become hubs and will take care of nearest spokes. Then it has a sustainability focus. By leveraging resources and expertise from both sectors, the model emphasizes long-term viability. The aim is to empower government systems while meeting immediate healthcare needs through private support. The Punjab stroke model is a testament to the potential of triple Ps in revolutionizing healthcare delivery in India. Its unique integration of advanced technology, collaborative governance, and a patient-centric approach sets a benchmark for other states to emulate. And on the same spoke and hub model, we are also going for treatment of hepatobiliary diseases. We have already STEMI working on it, and we are going for other diseases also. The same hub and spoke model we are going to implement. Thank you.
Yeah. Thank you, sir, for sharing the experience from Punjab. And this is the PPP model where we are a non-profit organization. So we have got some CSR funding to treat these patients who come for mechanical thrombectomy. So at least for a few years, we'll run the program and try to integrate with the universal health coverage schemes from Government of India. And so this is our plan, at least to demonstrate that this program works as in a PPP model. And the unique thing about Punjab is all the district hospitals have CT scans under PPP model. And also the AI technology also will be installed in some of these centers. So moving from Punjab, let us go to Kerala, one of the developed states and with a high literacy rate. Now, I've been working with Dr. Gopal almost 8 years now, I think, in the field of stroke, right from the inception of stroke units and training, etc. And they have developed a hub and spoke with hub as Sri Chitra Tenal Institute for Technology, and the spokes are the district hospitals. It'd be wonderful for you to share your experience of starting thrombolysis and how, with the universal health coverage, how we are able to integrate the thrombectomy in this program.
Thank you, sir. Thank you for the invitation to this program. Before going to the stroke program, let me just tell you, you all know about Sabrimala. It's a pilgrimage place. Almost 60 to 70 kilometers walk inside the forest to the temple. And last month was the Sabrimala pilgrimage. and two devotees, one from Tamil Nadu and one from Kerala itself, they had stroke in middle of the jungle, and they have half the way they had to walk back, they had to be carried back, and half the way they came to the district hospital Pathanamthitta, where we have a stroke unit. Both of them were thrombolized in the window period, and they could walk back to their home successfully. So like that, we have, out of the 14 districts, we have 12 stroke units in the 12 of our districts. All are equipped with thrombolizing facility, stroke rehabilitation facility, and a physiotherapy unit. We don't stop with thrombolysis. We give the after stroke care also with a dedicated physiotherapy unit and a physiatry unit. And the stroke unit is not just the meaning of the stroke management in Kerala. Right from the community level, under the support of Dr. Shailaja Madam and the Sri Tirunelveli Institute of Medical Sciences, we have trained our ASHA workers, our JPHMs, and our male health workers in stroke identification, stabilization, and management. That was piloted in 2 districts. What they will do is that they will go around to the houses. They will see all the patients who had stroke, whether they are complying to the treatment in order to prevent the repeat strokes, and also the people with hypertension to have their drug compliance in order to avoid stroke. So a community-based model is working in Kerala in 2 districts, and that has been published in a neurology in a vernacular. And the third thing is that we do have physiotherapy units in all the community health centers. A dedicated physiotherapist and a staff nurse is working in all the 227 community health centers just for the stroke management. And the training for the stroke physiotherapy was given from the Sri Tirunelveli Institute, and there is a module for stroke physiotherapy which has been circulated among the physiotherapists, and it is available in the website of the DHS also. So 3 days these physiotherapists will be in the CHCs, and 3 days they will be walking to the houses to give physiotherapy for the patients who are bedridden. So community level activities are also going on. And the question about the LVO, the large vessel occlusion, actually there is a pilot now going on with the Cure.ai in Kerala. We have taken the Sri Chitra and the medical college as the hub hospital, and the district hospitals as the spoke hospitals, and also the taluk level hospitals. And any case identified with the large vessel occlusion or with the bleed, they will be referred directly to the hub hospital without wasting much time in the spoke hospitals. So this is the pilot that we have actually started, and that will be implemented in the February this year, hopefully. And we are also mapping the stroke facilities in the districts, right from the primary care center to the stroke facility, stroke ready facility with the service of mechanical thrombectomy, where the patient has to be referred from the PHC to the stroke ready facility. Every district has to map, and that will be digitally captured so that the physician in the PHC or in the taluka level hospital can immediately refer this patient to the appropriate place without wasting much of the time. So these are the activities which are actually currently going on in the state of Kerala.
Yeah, thank you, Dr. Gopal, and amazing work, and I think years of, I would say, consistent efforts in training and having human resources at all levels. Particularly, I'm really amazed how you are able to have physiotherapists at CHC and staff nurse who have been trained and provide home physiotherapy also. I think this is a very good model to be replicated across the country, and training ASHAs, which we have done in Punjab also, one of the stroke care pathways research study that we did. We were able to train ASHAs, and ASHAs were able to identify stroke patient within the window period. So that is another important step for the state governments. We could implement an AI technology. Of course, as we progress in the stroke care, we need to reduce the time to treatment. So that is where technology comes into play. Thank you very much for that. And the next, we'll move on to Assam. Dr. Jacob from Baptist Christian Hospital. This is one of the areas where even now there's no neurologist. And about 4 years ago, the previous DG of ICMR, we were discussing, and he said that I have a lot of funds to be given for Northeast India. Why can't you develop a very innovative project like let us deploy mobile stroke units? So I was a little surprised. Who will spend about 8 crores, 9 crores to deploy and study? But anyhow, because of the request that came, so we wrote a project. The one site was Tejpur, because already with BCH Tejpur, we have had multiple research capacity programs, and Tejpur does not have a neurologist, so we included Baptist Christian Hospital and Tejpur Medical College. And in Dibrugarh, the Government Medical College in Dibrugarh was one of the centers. So in the country, in the government sector, there are only 2 MSUs deployed, one in Tejpur, one in Dibrugarh. And I request Dr. Jacob to share their experience. Every year there are new learnings, and even now there are new learnings from the program.
Thank you, sir. This was a pilot study from ICMR, funded by ICMR, and sir, the main thing that we had is we had no neurologist, and it was a physician-led model. What we first showed is that MSU, we can show a working MSU model. So when initially the MSU was proposed, we started from scratch. There was one previous MSU which was in Coimbatore, which was scrapped later on. So we had showed a working MSU model. That is the first thing, first achievement, what we can say. We had a working stroke unit, but also what we did was we initiated stroke unit in our neighboring medical college, which we had partnered with. So we did capacity building in medical colleges. We had taken a lot of classes, a lot of capacity building in our PHCs, CHCs, and a lot of other NGOs. Also, we had made protocols for stroke units, protocols for hypertensive management. Hypertensive management in stroke unit is easy, but hypertensive management as such in MSU, epilepsy management in while the patient is being shifted in MSU. Also, the assessments like NHS assessment in mobile stroke unit, NHS while the patient's in the ER, training the doctors for NHS, fever management, sugar management, and blood pressure management. With all these things, what we have found out that initially when a patient had come to our emergency department, they will be lying there in the bed. Even we never cared about like, are they in the window period or they are past window period, but they will come, and when the time is there to see the patient, we used to see the patient. So currently from house, like door to CT time from house has come to less than 10 minutes. Any patient who comes with a stroke, immediately, just like one person goes to registration, the patient is wheeled to the CT room for a CT. And once the CT is done, we personally see the CT. We had Cure also with us, partnered to see if there is an infarct or if there is a bleed. And if there is a need for thrombolysis, immediately thrombolysis was done. And our thrombolysis, door to thrombolysis time has come less than 45 minutes. With all these things, we had nearly 90 thrombolysis done in the last 2 to 3 years. And Tejpur Medical College, which was near to us, which started with 0, is starting to do thrombolysis now. We had capacity building for all the PHCs, CHCs, where patients with symptoms of strokes are immediately referred and not kept in the hospital. What another challenge we found out was we had a lot of problems with patients coming to the hospital. Like in one is in Assam, the literacy rate is little low, so patients don't know that they are having symptoms of stroke. And even if they know symptoms of stroke, they wait for the right person to come and take them to the hospital, or they go to the nearby Tea Garden Hospital where they are kept overnight, or they go to a PHC and they lie there. So bringing them to the right hospital was a difficulty. So we had to train all the CHC, PHC doctors and also the local hospital, including the pharmacists, the medical shop owners, everybody we had to talk with do classes in the ambulance drivers. We wanted to tell them that this is the right hospital to bring them. So we did all, even in IMA, we talked with all the doctors and we told them that there is free thrombolysis available in medical college and in our hospital. Another one thing we found out that we are missing all the 108 patients coming. So we went to the 108 call center. We talked with the call center people. We educated them about the stroke symptoms. And they, till then, they knew how they manage getting a stroke is like when the patient relatives say that there is a stroke, then only don't, okay, this is a stroke patient, but they don't do anything special. Once we taught them about what are the symptoms of stroke, they directed to the next desk where immediately these stroke patients are directly referred either to our hospital or to the nearby medical college where stroke thrombolysis is available. So these are the things which we have done till now, sir.
Yeah, thank you. I think we had a lot of learning experience from Tezpur and Dibrugarh. I remember in one of the patients in Dibrugarh, the patient, the 108 called from 100 kilometers away, and the MSU was informed. So the MSU was traveling towards the 108 ambulance, and they met midway, and the CT was down, and patient was thrombolized, and patient later on went to a private hospital. But so there are a lot of innovation that we have implemented in Tezpur and Dibrugarh. It may not be very fancy like the findings that we see in developed countries, but what we have seen is the early arrival to the hospital or calling the ambulance has increased. Thrombolysis rate in the hospital, both the centers have increased, and even in MSUs. One of the other things which I mentioned during my inaugural address was there's a high proportion of ICH patients, and many patients who are undergoing CT scan in MSU turn to be ICH patients. In one way, it helped us from the Indian Stroke Clinical Trial Network. We have a trial called intrinsic trial where we give tenexamic acid in randomized patient with ICH within 4.5 hours. I think at least 3 patients have been randomized in MSU for the trial. So there's a high volume of ICH patients. And so this is another innovative model with a lot of learnings. And it's towards the end of the project, we are just wondering how to scale up or what should we do next. And thank you, Dr. Jacob, for sharing the experience. So let's move on to Telangana. Dr. B. Naresh, who is the Executive Officer of Rajiv Aragyashri Healthcare Trust, and Andhra Pradesh and Telangana were one of the earliest states where they had implemented universal health coverage using the CM scheme. And this Aragyashri scheme has been a great boon to both the states for free access for acute care like heart attack and also stroke. So we would like you to share your experience. Yeah.
Thank you, sir. Mechanical thrombectomy procedure is a high cost procedure taken by Telangana government under Ayushman Bharat Rajiv Aragyashri scheme. This is the first state to include this procedure in Ayushman Bharat Aragyashri scheme. The request of NIMS hospital. The next, the future, the availability of specialty equipment and patients availability, it will be open to other private and government hospitals. Now, number of cases treated under stroke management in the last 10 years. Medical management of stroke syndrome in pediatric patients 662. Medical management of stroke, ischemic strokes in 53,057. Medical management of hemorrhagic stroke 16,500. Coil embolization of aneurysms 23 cases. All cases are under Rajiv Aragyashri schemes. And last year we increased 5 lakhs to 10 lakhs per family per annum for BPL families.
Thank you. I just want to ask how many thrombectomies we done? I just missed a figure.
In NIMS hospital, in this last 6 months, 8 cases are done. And we are open to other hospitals in private and.
Yeah, that's a good model for private and public hospitals working with the insurance scheme to deliver the treatment.
Under Aishman Arokeshri.
Thank you.
Thank you.
Thank you very much. Our last panelist is Dr. Swapnil Lal. He's DHS Maharashtra. Yeah. Morning he had shared the experience of home care model, and many times after patients receiving the medical treatment and some amount of rehabilitation, they go home, and sometimes they don't come back for rehab, and they may not come for taking medications. And this is the model of taking the care to the homes, home care model, and a nurse practitioner model. I would like you to share with the audience.
Thank you very much, sir. Respected dignitaries on the dais and off the dais. I want to describe couple of models practiced in pilot tested in state of Maharashtra. First is assisted home care model. Here, what is done? We are pilot testing a project to treat the survivors of stroke at their home. Because of the long duration of care required for these patients, it is not feasible or it is not advisable to admit each and every patient in the hospitals, but they can be very well managed at their homes. Now, what we have done, we have trained paramedical workers like multipurpose health workers and auxiliary nurse midwives. They, during their routine home visits for other program related activities, national health programs like immunization program, family welfare program, tuberculosis, leprosy, malaria program. This also is a national program in NPCDCS, National Program for Control of Stroke, Diabetes, Hypertension. They are doing their rounds into each and every homes. Now we have shortlisted the patients who require long-term care at their homes, and they visit per week, one visit per week, and they do all necessary things required as per the advice of the neurologist, like changing catheter or Riles tube or intracath, giving medications, following the regime prescribed by neurologist in their homes, and taking blood samples and urine samples for examination. All sorts of help will be given by the paramedical workers. And if necessary, with the help of eSanjeevani project, they can do a video call to their respective doctor and get advice from consultant also. And now we are in a proposal, we have moved a proposal to put the training of these paramedical workers in NCD program into the Pradhan Mantri Kaushalya Vikas Yojana skill development scheme. So they will be trained in that national scheme, and this will be very well a boon to long surviving patients in their fight against this non-communicable disease. Another model is nurse practitioner model. This is a model we are developing with a NGO called as FAVMI, FAVMI, that is a Family Voices about mental and neurological illnesses. This is a Mumbai-based organization, and with the help of them, we have developed a free-floating model. That means this is a independent model that can be financed with any sort of financial modes like out-of-pocket payment or risk pooling approach used in health insurance, or publicly funded model like government sponsoring. So this is a free floating model which is affordable, which is feasible. Here also there is a nurse practitioner who caters to about 20 or 30 odd patients per month, and she or he gives one visit per week for each patient, and if the condition warrants, the number of visits may be increased. And the nurse approximately gets 60,000 rupees per month, which includes her gross salary plus traveling allowance plus dearness allowance. Only the medications and surgical consumables are kept out of this purview. And here also we are planning to take the training component of these health workers, skill component into the Pradhan Mantri Kaushalya Vikas Yojana. And this is also a good initiative. We are pilot testing currently, and we are keeping our fingers crossed to success of this program. If the program succeeds, then it can be increased, the reach can be increased in phase-wise manner in the all over the state. Thank you.
Yeah, thank you, sir. And it's a very important initiative because the relatives and carers, they find it very, very difficult to manage these patients at home. And this, yeah. And so thank you for sharing your experience. And so the last speaker is Dr. Arpita Garg, a senior medical officer from Ambala City Hospital, and she's joining us virtually, and she's going to share the experience of Haryana. Yeah.
Good evening, everybody. Myself, Dr. Arpita Garg, SMO, posted at Civil Hospital, Ambala City. So we have started a stroke program in Haryana in 2020 through Angel. So currently it is implemented in 80 districts of state. Pre-requirement 24 hours CT scan, availability of drugs, injection altipase is available with us. Bedside INRs, all machineries working in our district hospitals. So at time to time, training of various staff, multidisciplinary meeting, checklist implementation, EMS training, stroke nurse certification training is going on. In Haryana, tenecteplase and alteplase are available at stroke care clinic in 18 districts. Time to time, patients are treated with these injections and variable results are seen. We feel very happy when we see patient walking on legs. So there are various challenges during the stroke management. Stroke care remains significantly underdeveloped due to lack of awareness among the critical window period for the treatment. We see people believe more on quacks, limited public centers that offer diagnostic and thrombolysis facilities, limited thrombolytic drugs availability, or lack of confidence in staff also to perform thrombolysis. Infrastructure obstacles, including delayed CT reportings, poor referral protocols, these are the challenges seen during the day-to-day practice. Government of Haryana is getting into collaboration with private hospitals, public-private partnership, developing stroke care pathway with the government hospitals and even medical colleges, creation of various spoke networks, hubs, and lay down clear guidelines and making pamphlet at district hospitals for the management of strokes, people to aware about the symptoms of strokes so that they can timely come to for medical aid. Mechanical thrombectomy is done at PGI Chandigarh. Project will be also executed under Ayushman Bharat scheme. Way forward for thrombolysis or stroke patient is data record to make future strategies more practical, including peripheral teams in the district level trainings, including grassroots level workers like ASHA workers, collaborating with officials from local self-governance, NGOs, registered practitioners, and local influence to increase the awareness about golden hours and effective management of cases. Connected with for making spoke model with medical colleges, effective implementation of referral protocol for transferring patient, 24 hours ambulance services, 24-hour CT scan operations, availability of drugs, prompt CT reporting. Thank you.
Yeah, thank you very much, Dr. Garg. And it's so good to see the number of patients who have been benefited and also the data that Haryana you're collecting. That is very, very important. Whatever we implement, we need to document. That'll be helpful not only for internal purposes, but also for quality and improvement. Thank you very much. So I'm going to summarize this session. We learned from 7 states the way they have implemented stroke care, the
सर ये
common
इधर भी आ रहा था
one spoke model.
ये वाला
There are some states where we have these PPP models that are available, and some states is completely government urban space model, urban spoke model, and thrombolysis is free of cost. That is very, very important. Most of the places it is integrated with the universal health coverage, the insurance schemes. And like innovative model like MSUs and the home care model. And it is very important that we need to learn from these models and see how we can implement in our own respective states. And also from Dr. Shekhawardhan, we came to know about how we can get funding for some of these programs in the states from the government of India. And thank you very much. I thank all the speakers and the panelists for giving their valuable inputs. Thank you. Photograph.
Thank you, sir. Thank you, sir, for this insightful panel discussion. Now I would request everyone to kindly be seated so that our honorable guest can come.
guest room.
Requesting everyone to be kindly seated and settled. As we approach the conclusion of this insightful summit, it is my privilege to invite our esteemed guest of honor, Dr. Balbir Singh, who's Honorable Minister of Health and Family Welfare, Government of Punjab, to kindly join us on stage. I would also like to invite the following distinguished dignitaries to join us on the dais. Dr. Jairaj Pandian, President, World Stroke Organization, Professor and Head of Neurology, Principal and Dean, Christian Medical College, Ludhiana. Mr. Gaurav Vyas, Head, IGT Systems, Philips, India. Mr. Ravi Walia, Member, FICCI Medical Devices Committee, Director, Government Affairs, Market Access, and GEM, India Metronics Private Limited. Ms. Leena Jasani, Deputy Secretary General, FICCI. Now I request Dr. Jairaj Pandian to kindly felicitate Dr. Balbir Singh. Thank you. Requesting Dr. Jairaj Pandian to kindly take over.
It's my privilege and honor to introduce Dr. Balbir Singh to this august audience. So he's the current Health Minister of Punjab, serving since January 2023. He's a member of Aam Aadmi Party and represents the Patiala Rural Constituency in Punjab Legislative Assembly. Before entering politics, Dr. Singh was an associate professor and an eye surgeon in Patiala. He completed his MBBS from Punjab University in 1979 and later pursued postgraduate degree in ophthalmology. Dr. Singh has been actively involved in various social movements, including the JP movement in 1974 and the 2011 India anti-corruption movement. He joined the AAP before the 2014 Indian general election and has held several key positions within the party. On a personal note, I would like to share a few snippets of Dr. Balbir Singh. I think it was in the Global Stroke Alliance meeting just before G20 meeting when World Stroke Organization arranged this ministerial 3 days program. And we had representation from 7 Southeast Asian countries and about 17 states from India, and 7 health ministers had attended that program. And Dr. Balbir Singh actively participated in the program. He was there all the 3 days, and he also signed the Global Stroke Declaration, which was released during that meeting in September 2023. That was probably the first step in terms of developing a stroke program in Punjab. Dr. Dheeraj and me, in 2016, we started training some of the district hospitals and medical college hospitals to establish stroke units. They started the program, and then COVID came and disrupted everything. And so this was a reinitiation of the project with a different model. And now, when I suggested that, let us make it as a PPP model, and we quickly, called for a meeting, and this was discussed. And finally, we signed the MOU on October 29th last year on the World Stroke Day in Chandigarh. And now the project is just taking off in all the district hospitals and 3 medical college hospitals. We are going to make 1 medical college hospital to begin with in the coming months as hub, because there is a biplane cath lab in Patiala Medical College, and we are going to train 1 neurosurgeon over the few months. So I would say, so many interactions I've had with him, and many times when I have a problem, I used to wonder, should I call him or message him? But just one WhatsApp message is enough. Within 20 seconds, there will be a reply. And so he's so open and for interaction. And this is my personal experience with him. So thank you very much. It's our honor to have you here. And thank you, sir. Yeah.
Namaskar, Sat Sri Akal, good afternoon. It's really a very big honor for me, a privilege for me to address this august gathering of doctors, members of the FICCI, I think delegates from most of the Indian states, and members of the industry also, those who are supporting us, angel investors. You see, stroke is a major, I would say, public health problem globally, with more than 15 million people affected every year, and close to 5 million people, they succumb to this stroke. Even in, you see, a country like India, I think, as we commonly say, that we are the diabetic capital of the world. So by default, we must be the stroke capital also. Though we don't have any reliable figures, do we have? at the national level. I think it's more than I think maybe a million patients which we have, those who suffer stroke every year. It must be that close to that 1 billion people, and half of them or 40% of them are young, in the very productive age group. So it's very imperative that we meet and discuss. I thank Dr. Jairaj Pandian for taking this initiative, and you see, we are blessed to have him in Punjab in Christian Medical College, that he is the president of World Stroke Organization. And it's because of his untiring efforts and Meditronics people that you see we have the first model in India where we have hub and spoke model, what they call it. And I must thank Anil Bonde MPG, is here, chairperson. He just left. And Leena Jaisani ji from FICCI, and all the people from Meditronics and everybody for making this possible. And when you have such a huge public health problem, it's necessary that politicians, particularly the government, from the government, and administrators and policymakers, doctors and industry people, they should sit together and find the solutions. And we have, I will be sharing very briefly with you, but you must have already discussed that Punjab model. So you have already discussed that. I think the stroke is like a, you see, American education system. It's not easy to get stroke. Right? So if your eating habits are unhealthy, if you are overweight, if you are suffering from diabetes, if you are suffering, if you have hypertension, and you are not taking proper treatment, you are not adequately controlled, and if you are blessed to be blessing this guy to be sitting to be living in a metropolitan city. How many of you live in metropolitan city? Maybe Delhi, Chennai, or Madras. How many of you? Most of you, huh? How many of you are smokers? How many of you are smokers? None? Do you mind if I say you are all chain smokers? Anybody living in Delhi is a chain smoker. Is that statement correct? So I think that's a very important risk factor, which is I would say not discussed, underestimated, or whatever it is. So most of us are chain smokers, and I would say more than 90% of the population of India is inhaling unhealthy air. Even the toxic food, I would say, even the water is not pure. So all these factors, I think the stress levels are rising, the lifestyle, sedentary lifestyle, and we don't have time for. How many of you exercise at least 1 hour every day? Very few, very few. You see, we are discussing stroke. So let the change begins in this hall. I think spending 1 hour for yourself, whether you are doing yoga, you are doing gym, or at least you are walking for 1 hour, that will make a difference. And how about meditation? You think meditation helps? It definitely helps in stress management. So I think if these two things, if we can, you see, take home the message, I think that will serve the purpose of a health minister, you see, of a state. And we should have this kind of, more often we should meet. And with Dr. Jairaj Pandian, and we have the people from PGI who are the Dr. Dheeraj is here, and so see, they are training our people. Dr. Jairaj is training our people. Now we are doing it. We did it for STEMI. We have quite a few initiatives which I can share with you, but I think the best ones, the latest one is hub and spoke model for the stroke, where we have all the district hospitals. Our DRME is here, Dr. Avinash is here. So I think, do we have the doctors from Government Medical College or from Punjab Medical Colleges also? Anyway, we are collaborating at the state level. We have CT and MRI scan in all the district hospitals. And you see, with the 881 Aam Aadmi clinics, which are from your home, within 5 kilometers, you will have a Aam Aadmi clinic, which is a primary health care. This is very important for managing diabetes and hypertension, diagnosing and managing. Then I think it's the second state after Delhi, now the only state where we have the trained yoga teachers in all the cities. Every half a kilometer or 1 kilometer, there is a yoga class going on in the morning, and more than 1 lakh people do yoga every day. Where we have the trained yoga teachers, their nutritional guidance, meditation, and some yogic exercise. So that there is a lot of demand for that and appreciation for that. I think that's how we can make a difference. So we are trying to do that, and then you see, it's very easy. The diagnosis is not, they call it fast, face, drooping of face, and there's a weakness of arm, and then speech, slurring of speech, and then treatment and time. That is very important because the most important factor is the treatment and time. Now we are providing for STEMI, that's the STB evaluation marker infarction, and this for stroke also we are providing medicine for thrombolysis in all the district hospital and sub-division hospitals, so that the CT is there and MRI is there in most of the hospitals. That it can be diagnosed, patient can be thrombolized, and then referred to the stroke ready unit, so which is tertiary care, which CMC is leading. PGI is there, then DMC people have started. We are going to start in medical colleges also. So we will have quite a few, close to, there are good private hospitals also in Punjab, in Mohali. I think Fortis is already doing it. I see they also do it. And then Max also, I think they have, or they are going to start. So we have close to 12 stroke ready unit which can do mechanical thrombectomy. And it's a, usually make a lot of difference to that patient, to that family. And of course, then there is a question of affordability and availability, which Medtronic people and FICCI, I request FICCI also, because Dr. Jairaj Pandian has made arrangements for 1.5 years, where the subsidized treatment is, or the free treatment is available for the patients in Punjab. I think we have to work out, the government of India and the state governments, and I sincerely hope. So we have the representatives from government of India. So you can take our message that we should work out a package for this, so that people, we have to make it affordable. You see, there is I have a cardiologist friend. Whenever he goes somewhere for lecture, now he'll say that patient suffered a cardiac problem. He went to the doctor and he survived. When he recovered after a few days, he was discharged. Then he was given the bill. It was 4 lakh rupees, and he suffered a second heart attack and he never survived. So I think affordability is important. It's very important. So that is where the FICCI and the governments and all of us, we can collaborate. And you see, I have a friend from AIMS Mohali who has written a book, Doctors Do Cry. It's a very, you see, it's a different collection of stories from doctors. When your patient is in distress, like you treat a patient, he recovers, you forget him. Now you make your best effort and patient dies. I think you can't sleep that night. It happens with all of us. There are many stories where the doctors have donated their own blood. They have tried to save a person. It was a young person that came to you and you couldn't help it. And then you see there is a patient, you don't know what is happening, what is the diagnosis. You are struggling, you are calling your colleagues. So I think doctors do care, and the society also appreciates it, and most of the people, I definitely, we have a lot of good doctors in government service. I do appreciate those who are working for the society. So it's really wonderful. I think I'm not qualified enough, though I'm an eye surgeon. So I looked at the retina and the optic nerve, it's window of the brain. So there were many instances where we could diagnose a tumor or even a cancer or something, looking at the fundus or hypertension, diabetes more often. But the only concern is that, you see, as an eye surgeon, that's my experience. Patients used to come to me with the vitreous hemorrhage and they were not even aware that they are diabetic. So they'll come to me with central retinal vein occlusion. We are treating the disease at the terminal stage. I think that's the pertinent point, the last point I would like to make. That is where the primary care and the secondary care come in the picture. That is where the role of the tertiary care, they have to train those doctors. Secondary care and tertiary care, that's what Dr. Pandian is doing. That's what the cardiologist has done. And we have a lot of collaborations. So I think we can work together, and this is a problem which is curable. This is a problem which is treatable, and there is no reason why we should not cure it, we should not treat it, and there is all the more reason to prevent it. And in fact, you see, I say it with some amount of regret. Are you open to this, that you go and talk to your IMAs or your professional bodies? You should write to the your state health ministers and to the union health minister. That is our fundamental right to breathe clean air. You provide us clean air. This is your problem. This is not our problem. We are being denied our fundamental right. If you see sitting in your clinic, or even if there are, how many doctors are there? 500,000 in India. If the 500,000 doctors write to the Union Health Minister or to the Prime Minister, I think there will be effect. When the doctor says something, everybody listens. The world will listen to you. Are you for that? You agree with that? I wrote to the IMA. I say where the governments fail, there the people succeed. So I think I'm maybe as a minister, but I feel very strongly about it. Like, you are living in Delhi, you see the national capital, but you don't have a clean air to breathe. What kind of, I mean, it's not a Delhi specific problem though. It's a whole of the India is like that, particularly the northern India. Southern states are still better, I would say. They're still better off, much better off than us. Northeast is the best for the environment problem of there. Less problem is there. So North India is the whole of northern India, starting from Himachal, Jammu and Kashmir, particularly Jammu. Kashmir is still slightly better than whole of India, Madhya Pradesh, Rajasthan, Punjab, Haryana, everything. Highly polluted air most of the time. I think there is not a single day in a year when it's a pristine air which is fit to breathe. So I think we can work together. Stroke is treatable, it is curable. And just to conclude, and we should meet more often, and we should express our feelings. So I think that's what I think, and I would prefer it should be a two-way process. It should not that politicians usually come and give the. I never read the, you see what is written for me. I speak from my heart. I think I hope you liked it, my views, and we agree on it. I would rather appreciate any feedback from you, any question from you for a politicians, or any suggestion from you.
Thank you, sir, for this insightful address. As we come to
One of my batchmate is there, Dr. Vijay is there from Mubala. Okay. You have a doctor who is member of ruling party? Any MLA from any MLA who is doctor from BJP? I won't know. Anyway. Thank you.
As we come to the end of this impactful summit, it is only fitting to take a moment to recognize and appreciate those who have contributed to its success. To deliver the vote of thanks, I now invite Mr. Gaurav Vyas to kindly take the stage.
As we approach to the conclusion of this National Stroke Summit 2025, it is my privilege to deliver a vote of thanks on behalf of FICCI. First, I would like to give my heartfelt gratitude to esteemed partner, World Stroke Organization, and the Indian Medical Parliamentary Forum, which has immensely supported and collaborated in making this event a successful event. Their commitment in advancing the stroke care and prevention is truly inspiring and pivotal in driving the impactful change that we are trying to deliver as a society. We are deeply thankful to Dr. Balbir Singh, who overcame his physical limitations also and came here with his presence in this event. And we are also thankful to Dr. Punya Srivastava, Secretary of Ministry of Health and Family Welfare, Dr. Anil Bonde, Honorable Member of Parliament, Chairman, Indian Medical Parliamentary Forum, Dr. Swasti Chandran, Additional DDG and Director, Ministry of Health and Family Welfare, Government of India, and Dr. Shikha Vardhan, ADJ, Ministry of Family and Healthcare. uh, Government of India for taking their time out from a busy schedule and joining us. Their presence has been truly encouraging to all of us. A special thanks to all the distinguished speakers, panelists, and the experts who shared their profound insights, innovation, solution, and the best practices that they do in their day-to-day work. Your contribution has not only enriched us in understanding the stroke care, but also have provided an actionable pathway for a critical healthcare challenges. I would also like to express my sincere appreciation to all the attendees from the healthcare, from industry, professionals, researchers, policymakers, and other stakeholders. Your active participation in engaging and is adding an immense value to today's deliberation and reaffirmed our collective resolve to combat the preventive conditions. A heartfelt thank to all our event partner, India Metronics, India Private Limited, Philips, Abbott, QRI, and all the support in making this event a grand success. Lastly, I would like to reiterate our collective commitment to insights and strategies shared during today. As we move forward, let us work together to strengthen the awareness on stroke prevention, build a resilient infrastructure that reaches out to the undeserved, and advocate for progressive policies that will facilitate the equitable access to all timely treatments. Let us today's summit be a springboard for our transformative actions. The journey doesn't end here. In fact, it begins from today. It's a new vigor and a shared responsibility that we all will carry from this event. Today, once again, thank you for your time, your ideas, your dedication, and your critical cause. Uh, Wishing you all safe journey back. Looking forward for a continued collaboration effort on the days to come. Thank you very much on behalf of Vicky. Thank you.